Hello everyone. Good morning.
Good morning, sir.
Good morning, sir.
Okay. So today is our first session of live class for NEET MDS 2023 and the 24 foundation batch. So this is going to be a kind of demo lecture for those who are not yet joined. So this session is live on the YouTube as well. Those who are watching on YouTube, welcome. In this session, we are going to discuss the first part of oral medicine and the topics of the first part, that schedule that has been given. Okay. So those who are joining from app, hello everyone. Good morning.
Good morning, sir.
Good morning, sir.
Good morning. So yeah, let's start with this session. So the first topic of the day is Vesiculobullous. Okay. So today is our first session of live class for NEET MDS 2023 and the 24 foundation batch. So this is going to be a kind of demo lecture for those who are not yet joined. So this session is live on the YouTube as well. Those who are watching on YouTube, welcome. In this session, we are going to discuss the so the first topic is Vesiculobullous lesion. Just a minute. Yes. So the first topic is Vesiculobullous lesion. Let's start with the session. Yeah. So first we'll see certain terminologies, so certain definitions, which in turn can be also be asked to you in exam. Okay. So the first ones are macules and patch. So basically, what is a macule? Macule is a flat and a pigmented surface area that is around 2 centimeters in diameter, as you can see here. Right? If it is in 2 centimeter diameter, a pigmented area, we'll call it as a macule. For example, a freckle. Right? If the area is more than 2 centimeter, we'll call it a patch. So both of them are flat lesion. Less than 2 centimeter is macule. More than 2 centimeter is patch. If it is raised above the surface, that is a small solid lesion of around 0.5 centimeter, we'll call it a papule. And if its size is more than 0.5 centimeter up to 5 centimeter, we'll call it a nodule. And if its size goes more than 5 centimeter, we will call it as a tumor. Now this can be asked you in exam. In which manner? For example, a dermal nevus is classified as, and the option can be given to you as patch, papule, nodule, and tumor. So obviously the dermal nevus, its size is more than 5 centimeter but below 5 centimeter, and it's a raised lesion and it's firm when you palpate. So it is basically a nodule. So that is how you are going. You have to apply the things that you are reading in theory into your practicals, or practically applying them in your NEET MDS or AIMS exams. Right. Next is a plaque. Plaque is a large flat top surface which is raised above the normal skin, around 1 centimeter in size. To that we'll call it as a plaque. For example, psoriasis or eczematous dermatitis. Then we have a vesicle, a fluid-filled small lesion, that is vesicle. If it's a clear, we'll call it as vesicle. If it is filled with pus, or as we can call it, filled with leukocyte, we'll call it as a pustule. A fluid-filled lesion raised, which is often translucent and histologically rising from below the basement membrane layer, we'll call it the bulla. that is more than 0.5 centimeter, and when this erosions or pustules or bulla, when they rupture, the top of this lesions will rupture, leaving the base of these lesions exposed, the raw area. This lesion will call them as erosions. Okay, so this terminologies, is it clear to everyone?
Yes.
Yes,
Yes,
everyone is
sir.
able to hear me?
Yes, sir.
Okay, so we'll move on to the next part now, that is classification of this vesiculobullous lesions. So this vesiculobullous disease for see, first of all, what I want you to know is, if you are preparing exclusively for the NEET MDS exams only, you don't have to remember the whole classification, or for that instance, you don't have to remember anything in much detail, as in you are remembering a short note that you used to, or you are preparing for your final year or third year exams. In our NEET MDS examination, whenever you go for the exam, the answer will always be in front of your face. You'll always be able to see the answer in front of you. You have to just choose one. So whenever you are reading these things, just try to get the concept and try to get the names when it is classification, that it is falling under which classification. You don't have to remember the whole of classification as such. Okay. So let's go on to the next topic, that is classification of the vesiculobullous disease. This is just for the preparation point of view. So this are classified into viral disease, immunological disease, and hereditary disease. The viral disease can be classified, just 1 minute. Yeah. So this viral disease are the herpes simplex, varicella zoster, hand, foot, mouth disease, herpangina disease, or these are viral disease which in turn appear as vesiculobullous lesions within oral cavity or on the skin. Now, in this topic, although we are discussing about the skin and vesiculobullous lesion, we are also going to discuss about this viral infections also. These are the topics that are overlapping each other. The next topic that we are going to discuss are the immunological diseases, or some of them are autoimmune diseases, which will cover Pemphigus vulgaris, mucous membrane pemphigoid, Bullous pemphigoid, dermatitis herpetiformis, and linear IgA disease that we are going to discuss in the next session. And the last one is hereditary vesiculobullous lesion, that is epidermolysis bullosa. This is one of the exclusive hereditary lesions which you can remember in your exam. That if they are asking you that which of the following is a vesiculobullous lesion of hereditary origin, in that case they'll give you these 4 options. Option A is Bullous pemphigoid, option B is dermatitis herpetiformis, option C is linear IgA disease, and option D is epidermolysis bullosa. So these are the 4 options which will be given to you, and you have to choose an answer. So you should remember that the hereditary origin of a vesiculobullous lesion comes under epidermolysis bullosa. Okay, now let's start with the viral infections. Now these viral infections as such can be classified based on the origin of the viral infection. So the first of the viral infections that we are going to talk about is a family of human herpes virus. Now human herpes virus, you can see there are total 8 types within them. Starting HHV is human herpes virus. So this HHV, a human herpes virus, can be classified into HHV 1, 2, 3, 4, 5, 6, 7, and 8. HHV 1 and HHV 2, both of this falls under HSV. Okay, so under HSV, now HSV also is classified as HSV 1 and 2, that is herpes simplex virus type 1 and type 2. Now, how are the different? They are different classically or theoretically based on the areas that they are affecting. HSV1, or as we see HHV1, is the virus that affects the areas which are above the waist level. So this will include our oral herpes virus infections, the labial infections, the cerebral infections, and all. Whereas HSV2 are the infections which are below the waist level. That will include the genital herpes infection, also the neonatal herpes simplex. So this can be asked you in exam, that neonatal herpes simplex is ideally caused by which of the following? HHV 1, 2, 3, 4. The answer will be 2 that you should remember. Okay. The next family in the HHV3 is the varicella zoster virus infections. That will include the primary infection, that is chickenpox, and the secondary infection, that is herpes zoster. This also we are going to discuss next. Then there is HHV4. HHV4 is Epstein-Barr virus, and the infections or the disease caused by this Epstein-Barr virus will include infectious mononucleosis, Burkitt lymphoma, and the other carcinoma. For example, nasopharyngeal carcinoma is caused by the Epstein-Barr virus. Then there is HHV5, which is cytomegalovirus, which will cause the chorioretinitis in AIDS, as well as atypical infectious mononucleosis. HHV6 and 7 will cause the conditions such as pityriasis gauzy, and HHV8, that is Kaposi sarcoma in AIDS. Now, these are the things you should, some of the things you should remember in your exam. Let's say we are talking about the Kaposi sarcoma. Now, this Kaposi sarcoma, based on this fact that we have seen, two kind of questions can be asked to you in exam. One is that Kaposi sarcoma is associated with which kind of infections? So it is associated with AIDS. Mostly in immunosuppressed patients, we'll see Kaposi sarcoma. That is, we'll see them in the patients with AIDS. That is the infection caused by HIV. But is Kaposi sarcoma caused by HIV itself? No. The Kaposi sarcoma is seen in the patients of AIDS who have decreased immunity, in whom there is another infection that is caused by human herpes virus 8 that leads to the Kaposi sarcoma. So if you are asked that Kaposi sarcoma is associated with which kind of infections, the answer will be HIV. But the Kaposi sarcoma is caused by which virus, then the answer will be HHV8. Is it clear to everyone?
Yes, sir.
Yes, sir.
Okay. Yeah. So let's move to the next topic. That is, we'll see each of this viral infection individually. So this is, as I told you, HSV1 and HSV2, above the waist and below the waist kind of classification. Now, this herpes simplex virus infections. Let's see the pathogenesis of this kind of infection. So first, let's assume there is a person who is a host who is seronegative, who has never come across or who has never got HSV infections. Now, this person will be exposed to another person who is already herpes simplex virus positive, or they have this simplex virus within them. Now, remember one thing: humans are the only herpes simplex virus reservoirs, only natural reservoirs of all the human herpes virus. And they have the ability to reside within humans throughout the life once the infection has taken place. So for a person who is seronegative, or the person who never had any kind of this kind of infection, to become positive, they have to come across in the contact with a person who is either primary or secondarily infected with HSV. So once they come in contact with this kind of person, they will become seropositive, and they becoming seropositive, they'll get the primary infection by this herpes infection. So primary infection mostly will take place in a, obviously we know the first time a person getting infected will be in a younger age. That this primary herpetic infection we will see in children, and then that condition is known as primary herpes simplex infection, that is herpetic gingival stomatitis, that will be seen in the child only. Now, this can be an obvious infection, a very severe infection, or it can be a subclinical infection that is not seen much, obviously. So the person becomes primarily positive. Now, after some time, because of our immunity, this person will be becoming negative. Okay. Now, once this person becomes negative, this virus goes and remain latent within our body. Usually, they remain latent in the nerve ganglia. Sometimes they may remain latent in the skin also. So this virus now becomes latent in a person. Now, this virus that is staying latent in our body can become activated secondarily also. This secondary activation can be caused by the trigger factors such as fever, menstrual cycle, stress, a list of reactivating factors are there that we'll see next. In this case, there will be secondary infection taking place. That will take place in our lip, palate or gingiva, depending on the nerve ganglia in which this virus was latent and which nerve ganglia part is become activated. That nerve will go and cause infection in the other area. Okay, and this person after secondary infection, after getting resolution, again becomes zero. It will remain seropositive, but the virus will become latent. So what happens? Let's say this person has got primary infection. Primary infection will be seen as gingival stomatitis. Let's say the person got infection in the gingiva, in the primary infection. Now, once this infection becomes, or as this infection subsides, this virus that is there in this gingiva will go and get stored in the ganglia, nerve ganglia, and it will travel through the nerves which are supplying the gingiva. They'll go and remain latent in the ganglia, and once they are reactivated, all the nerves which are going through this ganglia will be able to cause the secondary manifestation. For example, if the same nerve is going and supplying on the skin near the lips, it will lead to herpes labialis, that is secondary infection taking place on our lip. Okay, so that is how primary infection, it becoming latent, and then reactivation takes place. Okay, so this pathogenesis is clear to everyone. Anyone having any doubt regarding this?
No,
Am I
sir.
audible to everyone who have attended through the app?
Yes, sir.
Yeah. So this concept is clear to everyone, right? If you have any doubts in between, feel free to ask, but at least reply to me in between, so I know that you guys are attending and you are able to hear. Okay. So now let's move on to the next topic. That is, we'll see the individual infection. Now the first one is primary herpetic gingival stomatitis. That is primary infection of the virus taking place usually in the children. So this is caused by HSV1. As we know, oral cavity, the normal bacteria are HSV1. Sorry, the normal viral infection is through HSV1. It occurs in the children and teenagers, and there is a prodrome. Now there are prodromal symptoms. That means the symptoms taking place before the actual viral infection. And the prodromal symptoms usually includes the fever, loss of appetite, malaise, myalgia, headache, and nausea. Orally, what you will see erythema and clusters of vesicle either intact or ruptured. Once they become ruptured, they'll be appearing as ulcer. As you can see, once there used to be vesicle here, the herpes virus infection vesicle, but once it is ruptured, we'll be able to see the ulcers there. So this will appear on the keratinized mucosa of the hard palate, attached gingiva, dorsum of the tongue, as well as the non-keratinized mucosa of the buccal and labial mucosa. All these places will be filled with the clusters of the vesicles and the ulcers. Now this, as I told you, as these vesicles will break down, they'll form the ulcer. They can also coalesce together. They can join together to become a larger ulcer. Now this herpetic gingival stomatitis is ideally seen in the young age children only, as I told you, children and teenagers. If this infection is taking place in the infants or very young children, so in this cases, they'll not be able to tell that they are having pain or something like that. So the only symptom, now remember, there are these two things you should know. There is a sign and there is a symptom. Sign is what we find out when we are examining the patient. Symptom is what the patient tells us. Now, when we are talking in terms of symptoms for the herpetic gingival stomatitis in a children, so this has been asked in the exam, that which of the following will be symptom of the primary herpetic gingival stomatitis in an infant or a newborn child or a very young age child. So they'll not be able to tell anything. The only symptom will be refusal to take the food. Because they are in so much of pain, they will not be able to eat anything. So this can be asked in exam. Remember the symptoms of herpetic gingival stomatitis, the primary herpetic gingival stomatitis in infants or the small younger child, are refusal to take in the food. Okay, so clinically you will see fiery red gingiva, pharyngitis will be there. That will be difficult to swallow because of that, and the oral pain will be there. Now all these viral infections are self-limiting, and then they will resolve even if no treatment is done within 10 to 14 days. And immunocompetent patient. Immunocompetent means the persons in whom the immunity is working nicely, right? Now the next is infection of this herpes simplex virus on the skin. On the skin, we'll see three kind of infections: herpetic whitlow, herpetic gladiotum, and herpetic barber. Herpetic whitlow, which was mostly seen in the dentist in the old age when the gloves were not used. So let's say you are a dentist, you are treating a person who is having herpes simplex infection, and now this patient, because previously they didn't used to use gloves, so you'll be using or you'll be treating a patient without a gloves within their mouth, and this patient, and if your skin is not intact, there is a break within your skin, this virus can enter from patient's oral cavity to your skin, leading to the viral infection that is known as herpetic whitlow, right? Then let's say now the second term, herpes gladiotum, that is the cutaneous lesion mostly seen here in this area behind the ears, in the neck region. Now this kind of infection are classically they were seen or they are seen in the wrestlers. Let's say there are two wrestlers who are fighting with each other. One of them is having skin infection already with the herpes simplex. Now this person, when holds the other person like this, they transfers their infection to the other person. That leads to herpes gladiotum. And the third one is herpetic barber, that is infection spreading through the razors of the barber from one patient to another patient. So this is herpetic whitlow, herpetic gladiotum, and herpetic barber. Now let me tell you, or let me give you one condition, that there is a person who comes to you with the habit of a person, let's say 6 years of age, a child 6 years of age comes to you with their mother. The mother tells that this patient is having habit of thumb sucking, and they have come to you for this regular oral checkup only. Now in this patient, in addition to the oral findings, what you find is there is an ulcer present or a lesion present on the thumb of this patient. Now what can be this? What can be this ulcer present on the thumb? Anyone? A person with habit of thumb sucking, what can be this? He has ulcer present on the thumb. Now let me give you another hint that this patient within oral cavity is having fiery red gingiva and ulcers present on the tongue. Now in this case, if they are having ulcer on the thumb, what will be your diagnosis for the ulcer of the thumb?
Herpetic whitlow.
Yes, it can be due to the herpetic whitlow. That is, the infection from the oral cavity of this child has been transferred to the thumb or the digit, which he used to put within the oral cavity.
Herpetic whitlow.
Yes, correct. Okay, now let's move on to the next topic. That is recurrent herpes labialis. Recurrent herpes labialis is kind of secondary or subsequent reactivations of the viral infection that are taking place in the oral cavity. So this, as I told you, the virus that was there latent in the nerve ganglia, it has transferred to the nerves, to the skin or the area that the nerve is supplying, and there causing the secondary infection. Now this recurrent herpes infection of the mouth occurs in the patient who have experience of previous simplex infection, and during the primary oral infection, virus went to the ganglia and remained latent there and became activated to cause secondary infection. Now this secondary activation or the triggering factors, as I told you, are fever, menstruation, ultraviolet light, that is a person going for a longer duration in the sunlight, trauma, and emotional stress can be there. Okay, then you have this recurrent herpes labialis may occur either at the site of the primary inoculation where it was there or in the adjacent areas. Prodromal signs and symptoms also you will be seeing there. Okay, the common site for the, obviously it is, as the name says, herpes labialis. It will be seen in HSV1, this vermilion border of the skin of the lip and the adjacent skin, that is herpes labialis. It is also known as cold sores or fever blisters. You will see multiple small erythematous papules developing and forming clusters that is filled with fluid. And this vesicles will rupture and they'll crush within 2 days. This also will heal usually within 7 to 10 days. Now this recurrence can affect the oral mucosa except for the lips also. This is same, the area to which the nerve is supplying, where the ganglias were, ganglias in which the nerve was being resided by the viruses. So the recurrence in the oral cavity is limited almost always to the keratinized mucosa only, that is bound to wound. And the symptoms are less intense. The lesion begins as 1 to 3 millimeter of the vesicle that can rupture, or they can coalesce to form a larger lesion. Now remember one thing. If we are talking about the recurrent herpes infection in the oral cavity, as you can see, it is exclusively seen on the keratinized mucosa. But when we talk about another lesion or another ulcer, that is seen exclusively on the non-keratinized mucosa only. Can you name the lesion which is seen only on the non-keratinized mucosa? A very common ulcers in the oral cavity that you will not see anywhere else except the non-keratinized mucosa.
Aphthous ulcer?
Yes, the aphthous ulcer is exclusively seen on the non-keratinized mucosa, whereas this kind of recurrent herpes infection in the oral cavity, they are seen in the keratinized mucosa. Now, this, what I told you till here was the kind of reactivation of the virus in the immunocompetent patients, those who are having proper immunity with which you can fight this viral infections. But if you are immunosuppressed or immunocompromised, in this case, this viral infection can also become a very large or very, what you can say, problematic in that case. So what can take place in this immunocompromised patient is that lesion will continue to enlarge peripherally. As I told you in the previous types, they will subside within 7 to 10 days. But this kind of infection in the immunocompromised patients, what you will see on the skin, the lesion continues to enlarge peripherally. It will keep on increasing size from the smaller size to the larger size, and there will be increasing in the zone of the superficial cutaneous erosions. The oral mucosa also will be seen affected in the same manner. Now, regarding the diagnosis of this herpes infections. So first is cytology. Cytology means you take the skin or the scraping around the lesion and then you put it on the microscope, under the microscope, to find what the things are. So fresh vesicles are opened. We make a scraping on the base of lesion and place it on the slide to see under microscope. The stain usually used for this are the Giemsa rights or Vesiculobullous stains. These are the ones which can be used. Now, when you see under the microscope, now you have to remember the name of the stains also. This also can be asked you in exam. Now, what you have to remember is this test that we are doing is known as Zhang test. Cytology, we'll call it as Zhang test. Now, what are the features you will see? The following features are there. You will see multinucleated giant cells, ballooning degeneration of the nucleus. First, the cells will be multinucleated. As you can see, multiple nucleus are there. Within the cell, the nucleus will appear to get enlarged, as you can see in this case. So this we can call them as ballooning degeneration of the nucleus. And then you will see cinctia, that is within this epithelium. Here you can see this is the epithelium and exterior. You can see this bunch of cells due to acantholysis. These are the different cells seen there. Okay, so this is the Zhang test, which is positive for this viral infection. It is also positive with the other conditions that we are going to discuss next. So other ways through which you can diagnose, first of all, these are clinically diagnosable things. You don't have to go for all this detection, but sometimes let's say a person is immunocompromised and you're not able to get the treatment done properly, or the lesions are not healing. In that case, we have to do further investigation to find out what is the cause so that we can give the proper treatment. So this HSV antigen detection can be done with the help of the ELISA, that is enzyme immunoassay. DNA detection can be done with the help of the in situ hybridization. Electron microscopy, we can find out proper viral bodies itself. Cytology, histology, as well as PCR. Now, these are the things you might not know as of now. We are going to discuss them in detail when we are discussing microbiology diagnosis techniques. In that, all these things are being discussed. If you want to see it like as soon as this lecture ends, you can go to your video lecture session in microbiology. In the diagnosis section, all these things are discussed. There you can go through them. Still, if you have any doubts, you can always post on our group. We'll be discussing them. Okay. What are the differential diagnoses for the herpetic gingival stomatitis? The first one is recurrent aphthous stomatitis. Now, how you can diagnose recurrent aphthous stomatitis from the herpetic gingival stomatitis that we discussed right now? So, one thing is the primary herpetic gingival stomatitis or the recurrent, they'll be having vesicles, which will not be seen in the recurrent aphthous stomatitis. Regarding this site specificity, who will tell me the site specificity for the aphthous and the herpes infection? How are they different? We just now discussed.
Keratinized, non-keratinized mucosa.
Correct. Aphthous stomatitis will be exclusively on the non-keratinized, whereas this recurrent herpes infections which are taking place within the oral cavity will be seen on the keratinized mucosa. Remember, I am talking about the recurrent herpetic gingival stomatitis infection within the oral cavity. The primary infections by the herpetic gingival stomatitis are also on the non-keratinized mucosa only. They can be seen on the lips also. Okay, so we are talking about the recurrent herpetic infections, except for the herpes labialis. They are seen in the oral cavity, are seen on the keratinized mucosa. Others are herpangina, hand, foot, mouth disease, erythema multiforme. All these differential diagnoses are there, but because we are discussing them next, I'm not going into much detail. As we discuss them, obviously this differential diagnosis will become clear. Now, first thing is, before we go on to the next part, is the treatment part of this viral infections. The first thing you are going to do is to give the symptomatic treatment. The patient is under pain and they are not able to eat or drink anything. So we give them topical painkillers, or if required, systemic painkillers, so that there is enough of what you can say comfort level in the patient. Next, you will be asking for any viral infection, we'll be asking the patient to stay hydrated, drink as much water as you can. Next is use of magic mouthwash. Now, magic mouthwash is like a combination of certain drugs which will also help in relieving the pain. So, what is the combination of the magic mouthwash? The viscous lidocaine, diphenhydramine, and the covering agent. Covering agent, usually we use the kaopectate, Malox, and the aluminum hydroxide with the magnesium hydroxide in 1:1:1 ratio. So we have this Malox with aluminum hydroxide with the magnesium hydroxide into 1:1:1 ratio, along with the lignocaine diphenhydramine. So all these three things will be into 1:1:1 ratio that will be acting as magic mouthwash, which basically it reduces the pain. Now this magic mouthwash is not exclusively used for the herpes infection only. Any oral cavity lesions which are painful to the patient and they are not getting controlled with the regular painkillers, we can use the magic mouthwash with which the pain will be relieved. And then we have to do other symptomatic treatments, that is systemic analgesics. If the patient is having fever, we can give paracetamol, that is antibiotic, and topical local anesthetic drugs can be given. Secondary line of treatment. First is antiviral therapy. Remember, whenever there is primary herpes simplex virus infection or recurrent infection, antivirals are not going to act, that what you can say sufficient. Even if you don't use antiviral treatment, they are going to get healed. But when the person is having immunosuppression or immunocompromised patient, in those patients you might need to use the antiviral drugs also. Okay, so in this case you can give oral acyclovir 15 milligram per kg of the patient's weight 5 times a day. We have to reduce the duration of the fever with help of this antipyretics. We have to reduce the HSV shedding. We have to halt the progress of the lesions. We have to improve the oral take and other drugs. If acyclovir is not helping, we can use the femcyclovir. In case of recurrent herpes infection, you can use topical antiviral, that is 5% acyclovir with 3% pencyclovir. Now, even these agents that we are using for the topical treatment of the viral infection, you have to remember that these topical antivirals are only useful if you are using them during the prodromal symptoms or before the lesion appears. Now, as the name suggests, it is recurrent herpes simplex infection. Now, this recurrent herpes simplex infection, the patient is so used to this infection, even before the viral vesicles are going to appear in the oral cavity or on the lips, let's say for the herpes labialis, which patients will know that it is going to come there. They'll start getting this tingling sensations or the other prodromal symptoms as we discussed previously. So in this case, the person will know that, okay, I'm going to get this bout of infection or the lesion again. So in this case, these patients can use this topical acyclovir, 5% acyclovir, and apply in that region. So this is efficacious if applied 3 to 6 times a day at a first prodrome of a sign of lesion. Once the lesion appears, once there is a herpes labialis vesicle on your lips, this topical acyclovir are not going to help in any case. Okay, so remember, this can also be asked you next. And in case of immunocompromised patient, we have to do systemic antiviral drugs, and the patients undergoing hematopoietic stem cell. Now remember, immunocompromised are not only ones who are having any disease. Let's say a COVID patient is immunocompromised. Then a diabetic patient is an immunocompromised patient. But there are also immunosuppressed patients as well. These immunosuppressed patients are who? These are the patients in whom we have suppressed the kidney. Let's say a person in whom you are going to put a kidney transplant, or as you can see, a hematopoietic stem cell transplantation. Now, in this patient, we have to put these things, or we have to give the patient immunosuppressed agents so that there is enough amount of immunosuppression, so that there is no graft rejection. We are going to discuss about this graft rejection and graft versus host disease in the next session. So I'm not going into much detail as of now. Okay, and the immunocompromised patients in whom the acyclovir is not working properly, in those cases you can give foscarnet, a drug of choice. This can be asked to in exam. And see, now in the NEET MD's exam, they are not going to ask you a certain one-liners. It is not going to be one-liners being asked to you, or they'll not ask you straightforward that a person who is acyclovir resistant HSV infection in AIDS, which will be the drug of choice. They'll give you a case scenario that there is a person aged so and so diagnosed with HIV, started getting oral lesions on diagnosis for HSV, antiviral treatment with the acyclovir started, still the lesion is not responding. In this case, what will be your drug of choice? So in that case, you have to choose among the other answers the foscarnet. Okay, that is how you can answer this. So this was about the HHV, or the HSV 1 and 2, simplex virus 1 and 2 infection. Next is Varicella zoster infection. Now, as we know, Varicella zoster virus infection has two manifestations. First manifestation is during the childhood, or mostly during the childhood, and it is a primary infection that is known as chickenpox. So the chickenpox, also known as varicella or the herpes zoster, that is the secondary or the reactivation of this virus, that is shingles. So chickenpox, they represent primary infection by the Varicella zoster. Recurrence is possible as this secondary infection, that is herpes zoster. Virus is presumed to be spread through the air droplet. Usually you will see this in the school children. When they are playing together, a person got chickenpox, obviously they'll be playing together, it will spread through the air droplets, and they'll cause the secondary infection in the other children as well. The incubation period is usually 10 to 21 days, and then there will be reactivation of the virus. Or you can see incubation period. After that, there will be appearance of the clinical manifestation. What is incubation period? Incubation period is the period between the duration at which, or the point at which a person got infected. A person got in contact with another person through the droplet with this Varicella zoster virus infection, and the time at which the person got this clinical manifestations. So this is the thing. Between this 2 point of time, a person got the manifestations as on the skin or on the oral cavity. So this duration is incubation period, that is 10 to 21 days in the chickenpox. Clinically, you will see infection beginning with low-grade fever, malaise, pharyngitis, and rhinitis. The lesion will appear as a pleuritic maculopapular rash, which will begin on the face and the trunk, followed by extremities. So it starts from the center and goes outwards. Okay, this kind of centrifugal pattern of the wound. You should remember that there are certain lesions which start from the extremities, comes towards the body, and there are certain lesions which are starting in the face and trunk and going outwards. This Varicella zoster virus infections are this kind of infections, starting on the face and trunk, going towards extremities. Now, these lesions will rapidly progress through the stages of erythema, right? As you can see in this vesicle over here, surrounding this vesicle, is erythema, and in the center there is this vesicle. So this lesions, they rapidly progress through the stages of erythema, vesicle. That is, this appearance is known as dewdrop on the rose petal appearance. That is, the erythema is rose petal and the vesicle is the dewdrop. And they'll usually rupture or they may harden to get crusted. Okay. Usually the fever is present during the acute periods. In the oral cavity, what you will see, they'll be, obviously they are common in the oral cavity in the infection, usually seen on the palate and the buccal mucosa. The gingival lesion resembles those noted in the primary herpes simplex virus infection, but we can distinguish between them. They resemble primary herpes simplex virus infection, but the distinguish between the two is not difficult because the lesion in the Varicella zoster are painless, whereas the ones in the herpes simplex virus are painful. Okay, so diagnosis, obviously first is clinical diagnosis. A young child with this kind of appearance of painless vesicles, that is a chicken pox. If it is having atypical appearance, or if it is not getting treated nicely or properly, in that case we have to do the diagnosis to find out whether it is chicken pox only or some other thing. So for that, what things we'll do? We can do the viral isolation in the cell culture. We can do the rapid diagnosis from the fluorescent conjugated antibodies. We can use the detection of the Varicella zoster virus DNA, or we can use the pharma test, that is fluorescent antibody to the membrane antigen. The treatment, symptomatic treatment, we have to do antibiotic as well as topical antiviral medication within the first 24 hours of the rash that is seen. After that, it won't be used. We can use aluminum acetate soaps to provide the soothing effect. And the prevention, obviously, we have to give along with the MMR. You can give vaccination for the Varicella zoster virus infection also to prevent the appearance. Now it is herpes zoster infection. Herpes zoster infection will be the secondary reactivation of the Varicella zoster virus infection that you can see as herpes zoster. What will you see in herpes zoster? In the herpes zoster, that is also known as shingles, there will be, first of all, it will be seen in certain kind of patients, those who are immunosuppressed, those who are under cytotoxic drugs, or those who have undergone radiation for the malignancies, or it will be seen in the old age. Now, what will happen in this Varicella zoster virus infection is, as I told you, after the chicken pox, same as the herpes simplex infection, after the chicken pox, that is primary infection, the virus will go and get latent in our nerve ganglia. Now, once it has gone latent in our nerve ganglia, it can become reactivated there by the triggering factor, as I told, immunosuppression, fever, or the cytotoxic drugs, old age. All of them can reactivate it. And once it gets reactivated, it can spread through any one nerve. Usually, when we are talking in terms of the head and neck region, now affected by it is trigeminal. Okay, so it can affect either ophthalmic division of the trigeminal nerve, or it can affect the maxillary division, or it can affect the mandibular division. Okay, any of this division can be affected by this Varicella zoster virus infection. If it is affecting the facial, let's say it has gone to the facial. So in this facial nerve also, it can affect whole of the face as well, depending on which nerve is affected. Okay, let's say it is affecting the facial nucleus. So all the parts of this facial nerve through which it is transferring can get affected, leading to lesions unilaterally on the face. If it is affecting the facial nerve of the right side, it will affect the right side of the face without affecting the other side. Okay, so this is followed within 2 to 4 days of the appearance of crops of vesicles on the face. The pattern is unilateral, linear, and clustered distribution of the vesicle is seen with the ulcers and scabs in the dermatome supplied by the nerve. What is dermatome? Dermatome is the area of skin supplied by a single nerve. Now, if a single nerve is carrying this vesicle, all the area supplied by this nerve will be affected by the lesions. In the oral cavity, what you will see? The oral cavity, in this oral lesions occur with the trigeminal nerve involvement. So in this case, they will be present on the buccal mucosa, palate, gingival lid, often extending up to the midline. These individual lesions, they present as vesicles which ruptures to form the ulcer. In the oral cavity also, you can so nicely demarcated lesion. Only on this side there are the lesion. This side of the oral cavity is not having any lesions at all. Right? If the tip of the nose is involved, it is a sign that the nasociliary branch of the fifth cranial nerve is involved. Now this, of course, this line is taken from a textbook, but this can be asked to you in an exam in the form of MCQ also. When a person comes to you with involvement of half of the face with the Varicella zoster virus infection, they have given you the diagnosis also. There is involvement of the tip of the nose. So which nerve has got involved for causing the lesion on the tip of the nose? So this can be asked in exam. The answer there will be nasociliary branch. Remember, this can be asked and you have to answer accordingly. Now this facial paralysis and ear vesicles, when they are present, they can lead to pressure on the facial nerve, leading to facial paralysis. This condition together, along with the facial paralysis and the infections within the ear as well as the vesicles, we call them as Ramsay-Hunt syndrome. Okay, and sometimes there is a condition known as zoster sine herpes. That means there is a dermal distribution of the pain on the face, but the viral infection is not. As in viral infection is there, viral lesions are not. You will not be able to see vesicles or say all the other lesions of the infection. Still, that area of the face unilaterally is getting affected. So this zoster sine herpes refers to a condition in which dermatomal distribution of the pain occurs in the absence of antecedent rash. Okay, whenever after the usually after the condition is over, or sometimes during the lesion, there is presence of nerve pain or neuralgia. That is known as post-herpetic neuralgia. After the lesion is over, there will be presence of neuralgia in the patient. So this is seen in almost 50% of the patients who are affected and were having age of more than 60 years. Now, post-herpetic neuralgia, this pain can linger up to 30 to 120 days, and after the onset of the acute rash, it will be there. It affects up to 70% of the patients over the age of 50. The predisposing factors for the older age patients, and there will be prodromal pain, and there will be more severe clinical disease. It is seen commonly in the women, and 15 to 20% of these cases they involve trigeminal. Etiology, because the virus affects or it injures the peripheral nerves, it will lead to demyelination, leading to degeneration and sclerosis, leading to pain. How we are going to treat the post-herpetic neuralgia? The drug of choice for the post-herpetic neuralgia is gabapentin. Remember, you can use carbamazepamine, but the gabapentin is the drug of choice. Diagnosis is with help of the clinical presentation, viral cultures, cytological smears, and smears with the fluorescent monoclonal antibodies can be. The treatment, the therapy for the herpes zoster was directed towards supportive and the symptomatic measures. We are talking here about the herpes zoster. So we can give the supportive treatment is hydration therapy, and the symptomatic treatment is painkillers, topical or systemic. In addition to this supportive treatment, we also have to give antiviral treatment. It is not like the herpes simplex infection where it is okay if you don't give antiviral. Once you diagnose a patient with the herpes zoster, you have to start with the antiviral treatment. So what antiviral we are going to use? Usually used drug is acyclovir. Acyclovir is used for the treatment of this herpes zoster infection. Also, sometimes we can also have to give steroids. Now remember, steroids are usually contraindicated in the viral infection. If we are treating herpes simplex virus infection, we are not going to use steroids. But we have to use steroids during the treatment of Varicella zoster virus, that is secondary herpes zoster infection. Why? Because as we told you that during the infection there will be inflammation of the area as well. The area which is having ulcers or what you can call as this blisters on the face unilaterally will lead to swelling because of inflammation. And now because of this inflammation, this swelling can cause pressure on the nerves. Let's say facial nerve. It has caused pressure on the facial nerve, leading to paralysis of the face. Obviously, there will be transient paralysis of the face because of this condition. But if this condition remains for a longer duration, it can lead to permanent paralysis also. So to prevent this permanent facial paralysis or the Bell's palsy as we call it, caused by our this Varicella zoster virus infection, what we have to do? We have to treat this kind of cases with the steroids. The steroids, what they'll do, they are basically anti-inflammatory agents. Now this anti-inflammatory agents will reduce the swelling so that there is no any Bell's palsy taking place. Okay, this is this herpes simplex and herpes zoster infection clear to everyone?
Yes, sir.
Yes, sir.
Okay, so now we are going to have a 5 minutes break at this point, and after 5 minutes we are going to continue again in the same session. So stay here. Okay, everyone.
Yes, sir.
Am I audible to everyone?
Yes, sir.
Yes, sir.
Okay, so we are going to have a 5 minutes break. We'll continue within 5 minutes from now.
Yes.
Hello everyone. Let's resume with the remaining session. Can you all hear me?
Yes, sir.
Yes, sir.
Okay. So yeah. So next session is our Coxsackie virus infection that we are going to discuss. So this infection usually will include herpangina, hand, foot, mouth disease, and acute lymphonodular pharyngitis. So first, we are going to discuss about herpangina. So this herpangina, you can remember, a classical feature is that it will affect the posterior part of the oral cavity, caused by group A Coxsackie virus, reported in the sporadic outbreaks, and seen in the younger children and sometimes adults as well. Clinically, you will see in the mid and short duration. It will begin with the sore throat, low grade fever, headache, and this prodromal symptoms can also include the vomiting, prostration, as well as abdominal pain. Yeah. So the patient, after the prodromal symptoms, they'll start exhibiting ulcers. They'll show gray base on the ulcers, which inflame periphery, and usually they'll be seen in the, as I told you, posterior areas of the oral cavity. That is anterior facial pillars on the hard and soft palate, and posterior pharyngeal wall, buccal mucosa and tongue. As we know, because these lesions are in the posterior part of the oral cavity, definitely there will be difficulty in the patient to swallow or to eat. So how do you differentiate it with the herpes simplex virus infection? As I told you when we were discussing about the differential diagnosis of the herpes simplex virus infection, I had told you we are going to discuss the differential diagnosis next. So first thing is herpangina occurs in epidemics and HSV doesn't. That is, let's say it is taking place in the school children, multiple school children will be having herpangina, but that is not the case for the herpes simplex virus infection. It is a milder condition than HSV. The lesions of this herpangina, they occur on the posterior portion, whereas the herpes simplex virus infection are usually on the anterior portion of the mouth. Herpangina does not cause generalized acute gingivitis, which is seen in the herpes simplex virus infection, and herpangina tend to be smaller in lesion than the HSV. In the laboratory findings, what we will see? We will not see ballooning degeneration or multinucleated giant cell as we had seen in the herpes simplex virus infection in these cases. And the treatment is directed toward the symptomatic relief. We don't have to do the antiviral treatment here. Another example caused by Coxsackie virus, hand, foot, mouth disease, as the name suggests, it is seen on the hand, it is seen on the foot, and it is seen around the oral cavity also. This also is seen in epidemics. It is also seen in the children mostly. Okay, so the oral lesions in these cases are along with the hand, almost present. Sometimes it may or may not have the lesion on the feet. The cutaneous lesion, they range from the dozens of primarily affected borders of palms and soles, as well as ventral surface and side of the finger and toes, as you can see in the image. Oral lesions, they resemble those of herpangina, but they are in more numerous, and sometimes they are not, mostly or always, they are not confined just to the posterior. They are seen in the anterior areas of the oral cavity as well. Okay, so this was about the virus infection. Next, we are going to discuss about the immunological condition that appear with the what you can call as this vesiculobullous lesions. So this vesiculobullous lesion in the immunological condition, the first one we are going to discuss about, the one that is most common or very important from our point of view, is Pemphigus vulgaris. Now this Pemphigus itself is from a Greek word called pemphigs, which means bubble. You will see genetic predisposition to the HLA class 2. In this cases, not much important for you, don't go into much detail for that. Age group is 4th to 6th decade, right? And for understanding the mechanism of this Pemphigus vulgaris, we have to understand how is the epithelium structure, or what is the epithelium structure. So our epithelium is made up of, or a skin or oral mucosa is made up of epithelium, and below the epithelium we have the basement membrane, and within the epithelium we have the cells. So let's say we are talking about the basal cells. So epithelium cells, they are connected to each other, and epithelial cells, they are connected to the basement membrane also. So it is connected to basement membrane here as well, and they are connected with each other also. So of course, there are many mechanisms through which the cells are connected to each other, like tight junctions, gap junctions, and adherents. One of them is desmosome. With help of desmosome, cells to cell attach with each other, and with help of the hemidesmosome, the cells connect with the basement membrane. Now, cells to cells connecting with each other and the cells connecting to basement membrane, these two components, desmosome and hemidesmosome, are important for us when we want to understand the mechanism or the pathogenesis of the Pemphigus vulgaris. So as I told you, these two cells, let's say these are two cells, the cells are joined with each other with help of the desmosome. As you can see, these are the desmosomes. Now, desmosome also of two types, desmoglin. Now, desmosomes themselves are made up of proteins. Desmoglin, that is DSG. It can be DSG1 or it can be DSG3. Okay, and they are also connected with the basement membrane. The cell to cell connected with each other with help of the desmosome, and the cell connected with the basement membrane with help of the hemidesmosome. You can remember in these terms that desmosome have cells on both of their sides. That's why desmosome. Whereas hemidesmosome, they have their cell only on one type. That's why hemidesmosome. Okay. So this desmosomes can be of two types: desmoglin 1 protein and desmoglin 3, DSG1 and DSG3 are there. Okay. Now what happens in the Pemphigus vulgaris or any other autoimmune condition that I'm talking to you about? That is our autoantibodies. What is an autoantibody? Now, usually, what is the function of antibody? Antibodies will go and act on any foreign body that we call as antigen. They'll go and act on antigen, they'll bind with it, they'll call the immune complex at this site, and it will ultimately destroy the antigen that our body finds that it can be harmful to us. Usually, these antigens are viral bodies, bacterial bodies, or any other foreign bodies, right? But in case of the autoimmune conditions, our body will find our own proteins or our own components as antigen. For example, in this case, when the cells that are connected to each other, this desmosome is there, let's say DSG1 and DSG3 proteins are there within desmosome. Now, in the autoimmune conditions such as Pemphigus vulgaris, our body will find this proteins of DSG3 and DSG1 as something that is coming from outside. They'll find them as antigen and they'll go and act on this structures. Now, just imagine that these two cells are connected to each other with help of this proteins. Now, if our body itself will go and break those structures, what will happen? These two cells which are together will be separated apart, right? That is what is happening in Pemphigus. That is acantholysis. Acantholysis is loss in the connection between the cells, usually in the spinous layer that we are going to discuss next. Not to go into much details of. Okay. So now there are different kinds of Pemphigus. Pemphigus is not just one type. As you can see, a Pemphigus vulgaris. If we talk about that, also is involving only mucosa or skin. We have Pemphigus foliaceus and Pemphigus that is induced by drugs. So let's say we are talking about Pemphigus vulgaris, including skin, and we are talking about Pemphigus vulgaris, including mucosa. So certain Pemphigus vulgaris will not have any finding on the skin. They'll be having finding only in the oral mucosa. And certain Pemphigus vulgaris will not have finding on the oral mucosa. They'll be on the skin only. What is the reason for that? Of course, we know that this Pemphigus vulgaris is going and affecting the desmosomes. And desmosomes are there in the oral cavity also, on the skin of oral cavity. It is there on the mucosa of the oral cavity. They are there on the skin of the body also. So why some certain Pemphigus vulgaris affects oral cavity only, and certain Pemphigus vulgaris affects this skin only? The reason behind that is desmoglin 1 and desmoglin 3. As you can see here, the desmoglin 1 is seen in the skin epithelium, and desmoglin 3 is seen in the epithelium of the oral mucosa. So what will happen? whenever there is a pemphigus vulgaris condition in which there are autoantibodies generated against desmoglein 1. Now, which ones are generated is not in our hands, but in or like we don't know that which one is generated at which stage. But if DSG1 autoantibodies are generated, what they'll do, they'll go and affect the skin. So if there is autoantibody to DSG1, the skin lesion you will see in the pemphigus vulgaris, and if there is autoantibodies generated again DSG3, the lesions you will see in the oral cavity will be against the oral epithelium. Okay, so this pemphigus vulgaris localized to mucosa. In this case, the localization of the antigen will be on the desmosome, that is for all the pemphigus vulgaris. But the main antigen in this case will be DSG3 in case of mucosa. If it is involving skin and mucosa both, it will affect DSG1 and DSG3. If it is pemphigus which affects only skin, for example, pemphigus foliaceus, so in this case the antibody will be to DSG1 only. And there is drug-induced pemphigus which affects the oral mucosa only. In that case, the antigen will be DSG3 only. Now remember, this can be asked in exam, that which antibodies causes pemphigus vulgaris, and they'll give you example of IgG, A, M, D, and E. The answer will be IgG, right? So two things can be asked to you about pemphigus: antigen and antibody. A pemphigus condition involving skin, pemphigus condition involving the oral mucosa. Now, who will tell me the antigen which will be affected in the pemphigus involving skin? What protein will act as antigen in this case?
DSG1.
DSG1. Very good. And for the one that is affecting oral mucosa,
DSG3.
DSG3.
it will be DSG3. Now, let me ask you in this manner. In case of drug-induced pemphigus, which protein is affected?
DSG3.
It is DSG3. In case of pemphigus foliaceus,
DSG1.
DSG1.
this can be asked you in this term also or the other term that I don't know also. And which will be the antibody for skin-related this pemphigus?
DSG1.
No, it is, we are talking about antibody. DSG1 is antigen.
IgG.
Antibody is
IgG.
IgG.
Correct. And in case of oral mucosa, it will be?
IgG.
It is G only. For all kind of pemphigus, the antibody is IgG only. The antigen differs. If it is affecting skin, it is DSG1. If it is affecting oral mucosa, it is DSG. Is this clear to everyone?
Yes, sir.
Yes, sir.
Okay. And the lesion, depending on the antigen, you can also be asked in this manner also, that autoantibodies generated or the IgG autoantibodies generated against the skin desmosome affects DSG3. Which of the following, or there is a DSG1, which of the following will be affected? So you have to find out a pemphigus affecting the oral mucosa. That will be the answer, right? So this is what we already discussed, that whenever the antibodies are against DSG1, that is anti-DSG1, it will affect the skin only. It will not affect the mucous membrane. There will be no mucosal lesion. If it is DSG3, there will be mucosal lesion, but there will not be any skin lesions. But if both of them are there, there will be skin lesions as well as the mucosal lesions. Okay, all these things will be available to you for the online course students in the lecture notes section. So there, if you want to go through this again, so you'll be able to do it. Okay, so this we already discussed what is happening in pathogenesis. The antibodies are going and acting on this desmoglein 3 and causing the breakdown, leading to acantholysis. Okay, so this we already discussed. The etiological classification. What are the etiologies that generates this condition? Garlic. Garlic can cause pemphigus. Remember, there is that. Second thing is drugs. What drugs? One is sulfur drugs, that will including penicillamine and captopril, and non-sulfur drugs such as phenol, rifampicin, diclofenac, ACE inhibitors. All of them can lead to pemphigus onset. Certain virus infections such as herpes virus infection can lead to pemphigus, and other factors such as high exposure rates to pesticides or high number of female patients who are pregnant that is suggests that the estrogen may be responsible for the condition of pemphigus. So this can be asked to in an exam, that which of the following hormones may be responsible for the onset of pemphigus. The answer will be estrogen. Clinically, what you will see, the age of patient will be mostly around or more than 50 years, seen more in the females. And on the skin and other sides, you will see these lesions resulting in superficial blisters. And these blisters, when they rupture, it will lead to ulceration. Other mucosal surfaces are also involved. The mucosal surfaces means the ones on the mucosa, that will include oral cavity, nasal cavity, ocular cavity, and the genital also can be affected in these cases. Right now, oral manifestation in specific. The oral cavity, what things will see? Blisters, erosions, ulcer. Blister is first, it will appear as a vesicle of blister. When it ruptures, it will lead to erosion, ultimately leading to ulcer when they join together. So oral lesions rapidly rupture and ulcerate on the buccal mucosa, palate, and lips. Sometimes this bulla you may not be able to find in the oral cavity of the pemphigus patient because they are so fragile that they'll rupture because of the friction taking place in the oral cavity. They begin on the non-inflamed base and they break and cause irregular cluster of the ulcers. Now, edge of these lesions, they extend peripherally until they involve large portion of the oral mucosa. So you will be able to see a large single ulcer instead of multiple small ulcers. You will see Nikolsky's signs being positive, that will lead to formation of the new lesions after gentle mechanical pressure. And on the gingiva, obviously you will see discriminative gingivitis. Now remember, this Nikolsky's sign is positive for Pemphigus vulgaris, that is applying the pressure on the normal area, you will be able to see formation of a new blister, that is Nikolsky's sign. And on the gingiva, you will see discriminative gingivitis. Now, discriminative gingivitis itself is not a diagnosis, but it's a feature. It is not only seen in pemphigus. Discriminative gingivitis is also seen in other conditions such as Lichen planus as well, that we are going to discuss in the next sessions. Now, this, because there is so much of ulcerations and vesicles around the body, these patients have profuse salivation and halitosis. There will be extension of this condition into the esophagus, pharynx, larynx with oropharyngeal involvement, which will lead to painful dysphagia. What is dysphagia? Anyone? Can you tell me?
Difficulty in swallowing.
Yes, that is difficulty or pain during swallowing. That is dysphagia that we are going to see. How do you diagnose this? First of all, full history and examination based on clinical finding itself, you can at least suspect that is pemphigus. Then we have to do biopsy. In the biopsy, what thing we are going to see? We are going to see intraepithelial blister formation, and we can do certain immunological investigation as well, such as immunofluorescence. So for biopsy, we have to take two specimens. One is from the lesion itself, and other is from the perilesional tissue. The first specimen, what we'll do, we'll take it from the lesion, we'll immerse them in 10% neutral buffered formalin, and then we do the routine histopathological investigation. What it will reveal? It will reveal characteristic acantholysis. That is, acantholysis means loss of cell-to-cell adhesions within the epithelium. That is known as acantholysis. And as we know, as we have seen in the pathogenesis, that in pemphigus, this cell-to-cell adhesion is lost. So obviously, it will lead to acantholysis. That is what we will be able to see in the this histopathological investigation. So here you can see, if you see this image over here, this part is basement membrane. These are the retiringes or retipex. So you will see these things within the epithelium, this blister formation. That is characteristic of our pemphigus. And the first biopsy specimen we are used for the histopathological examination, in which we saw the this intraepithelial blisters. The second specimen will take from the perilesional tissue, that is the normal skin, and then they'll place on the gauze pad, which is soaked in the holding solution. That is, if you have to carry it to the lab. Now this specimen we have to use it for the this immunofluorescence. That's why we are talking about. Okay. So if the lab is nearby, then you can send the specimen to the lab within 24 hours. If it can be sent within 24 hours, you can just put them on the gauze pad, which is soaked with the saline. But if we have to send it to a place where it will take more than 24 hours. Let's say you have taken a specimen in Delhi and you want to send this specimen to the lab which is there in Bangalore. So it will not reach there in 24 hours through the lab facilities. So it will take more than 24 hours. So for that case, we have to use Michel's solution. So this Michel's solution is used when you want to send it, this specimen for the immunofluorescence investigation, and it is going to take more than 24 hours. Less than 24 hours, select. You have to remember this. Okay. Now, once it has reached the lab, we have to do the immunofluorescence. Now remember, immunofluorescence can be of two types: direct immunofluorescence and indirect immunofluorescence. Let's see the first one. First is direct immunofluorescence. What we will do, direct immunofluorescence means we are going to take the patient specimen itself. That is like the specimen that we have taken from the patient, from the normal skin. This normal skin specimen that is there in the lab, what we'll do, we'll apply fluorescein conjugated anti-human immunoglobulin antibodies. Now these are antibody to antibody. You getting my point? What we are doing, we have taken a normal skin of the patient. This normal skin of patient, if the patient is Pemphigus vulgaris positive or it is having Pemphigus vulgaris, this skin is already going to have immunoglobulin antibodies attached to the cell-to-cell junction, that is desmoglin, right? Already those antibodies are there. We have to add antibodies to this antibodies on this specimen, and this antibodies that we are adding on this specimen, they'll be conjugated with the fluorescein. Fluorescein means something that is going to fluoresce when we see in the microscope. So when you see this under the microscope, what will happen if the antibodies are already there? This anti-human immunoglobulin antibody will go and bind to this particular antibodies and they'll fluoresce from the area where they are present. So what you will see? You will see presence of the fluorescence on the microscope. Is it clear to everyone what I just now told you?
Yes, sir.
See, again, I'm just telling you quickly. Let's say this is the specimen that we have, and this in this specimen, this is the epithelium part, and in the epithelium, between the cell-to-cell junctions, we are going to have antibodies because the patient is already having these antibodies against Pemphigus cell-to-cell adhesion, desmoglins. Okay, already these are the places where antibodies are there. Onto this, you are going to add anti-Ig antibodies. So in this case, this antibody will go and bind to the antigens, that is immunoglobulins. So when both of them join, this antibodies, the one that we have added, will be present in this area. And what does fluorescence mean? They'll emit light out of them. So when you see in the microscope, you will be able to see light in this area of the skin, or within the epithelium, you'll be able to see the light. That is direct immunofluorescence. Okay, so now you are confirmed that the patient's skin is having antibodies at the desmoglin, right? Now you want to find out indirect way. What is indirect way? In indirect way, we have to take patient's serum. By serum, that we have to find out whether the antibodies are there on the skin only, or the antibodies are there throughout the body of the patient. So that how we get antibodies are usually present in the serum. So we'll take blood from the patient. Now this blood obviously will take serum out of it through the procedures required, and this serum we are going to put on the specimen of another epithelium. Usually it is used, the epithelium used is monkey esophagus. Now on this monkey esophagus, we'll put the serum of the patient. Now this serum of the patient will be already having antibodies already within them, and then what we'll do, we'll wash off the excess. So this, if the patient's serum was having antibodies, it will go and bind to the desmoglin present on the monkey esophagus specimen, right? Then again what we'll do, we'll again put the anti-human immunoglobulin antibody. Now at this point, we'll start with this process. we'll put the anti-human immunoglobulin antibodies there, and then we will check on the microscope. So in the direct one, what we did, we put antibodies against the immunoglobulins that was already there on the human skin or the patient skin. That's why it is direct. In the indirect, what we did, we took the serum of the patient. Now the serum of the patient was put on the monkey esophagus. Because the serum was having immunoglobulins, it went and bound with the desmoglins of the monkey's esophagus. That is same as human esophagus. That's why we are using desmoglin. Now at this point again, what we'll do, we send this first antibodies. Now we'll send second antibodies to even this antibodies. Antibodies acting against the first antibodies that will go and bind to this area again, and you will be able to see the fluorescence. So that is indirect immunofluorescence. Is it clear to everyone? Yes, am I audible to everyone?
Yes, sir.
Yes, everyone got this point that I just now told you?
Yes, sir.
Yes, sir.
Yes. Okay. I guess everyone has got this. Jay, you got the point?
Yes, sir.
Okay. So we have taken two specimens from the patient. First specimen is used for the histopathological examination. Second specimen we use for the immunofluorescence. So this is how we are going to the diagnosis part. So when we are doing the direct immunofluorescence in the patient, what you will see? You will see a pattern known as fishnet appearance. As you can see, this is the fishnet appearance of the immunofluorescence. What will happen? All these antibodies will spread across the cells. As we know, this is epithelium, and within the epithelium we have the cells. These are the cells within the epithelium, and within the epithelium, these cells are joined together with the desmosomes. Right? These are the desmosomes joined with each other, and these desmosomes have DSG3. We are talking about the oral cavity. This DSG3 were acted upon by this fluorescent antibody in that our direct and indirect immunofluorescence. So these areas will start fluorescing. So this appearance will appear as if this cell itself will not appear fluorescent. This you can say the darker part are the cells themselves, and the lighter part here, the ones which are glowing, are the fluorescent antibodies present between the cells where the antibodies were there. So this kind of appearance is known as fishnet appearance, which is classical for the pemphigus vulgaris. So if a patient comes to you with the lesion and you want to diagnose whether it is pemphigus vulgaris or whether it is pemphigus or the bullous pemphigoid, the lesion being same in the oral cavity. So with help of this, you can find out that because the fluorescence is throughout the oral cavity, throughout cells in the epithelium leading to fishnet appearance, this condition is pemphigus vulgaris. Is this clear to everyone?
Yes, sir.
Yes, sir.
Okay. The differential diagnosis, first is recurrent septum stomatitis. We can obviously differentiate it from the severity of the lesions. Lichen planus, the bullous lichen planus may appear like this, but it is not usually so much generalized. And the other feature also that we are going to discuss next. Erythema multiforme. Erythema multiforme, you will see crustation of the lesions on the lip, and on the clinical examination or the immunofluorescence and all this examination, you'll be able to find differentiate them. And also the pemphigoid, we can differentiate it based on the histopathological examination. Next is treatment of the pemphigus. How we are going to treat the pemphigus? Now this pemphigus involves treatment aiming at improving oral hygiene, minimizing irritation, and symptomatic treatment. Improving oral hygiene so that there is no secondary infection. Now what happens in pemphigus vulgaris patients is, because there is so severe pain, the patient is not able to even brush that or do the regular oral hygiene activities. That can lead to secondary infection, leading to other complications also. Okay, and because the patient, when they try to eat, the skin is so fragile, it can lead to secondary irritations also. So we have to minimize that. The treatment is mainly immunosuppression with help of the corticosteroids or certain steroid-sparing drugs such as azathioprine, methotrexate, and cyclophosphamide. Now, severity of the disease is related to proportion of DSC1 and DSC3 antibodies. Which antibodies are more? This I don't need to go into much detail. DSC1 is more, more oral lesion, DSC3 is more will be our DSC1 is for the skin lesion, DSC3 is for the oral lesion. So along with the clinical feature, it may be useful in determining the treatment needed for the treatment outcome. So we use steroid and the steroid sparing drugs, and these are the list of the side effects that these drugs can have. So I'm not going into much detail of the side effect one by one because I just have to tell them the names of them for you. So what you can do is after the lecture is over, you can go to the lecture notes that will be available in your account. Then you can go to the lecture note and read this side effects as well. Okay. So this mechanism of the steroids, how they are going to help in pemphigus. Steroids are basically anti-inflammatory drugs. What they'll do? They'll reverse increased capillary permeability, leading to reversal of the antibodies exiting to the site from this capillaries. Okay, they'll suppress this PMN activities, polymorphin nucleoside activity will be reduced. Then they'll stabilize the lysosomal membranes and they'll suppress the lymphocyte and antibody production, leading to decreased autoimmune activities. Now we have certain steroid sparing drugs. Steroid sparing drugs means a treatment, immunosuppressive treatment where you are not going to use the steroids. So steroid sparing drugs usually include azathioprine that will antagonize the purine metabolism, which will inhibit the synthesis of the DNA, RNA, and the proteins, ultimately leading to decreased production of the antibodies also, and they'll decrease the proliferation of the immune cells, which will result in lower autoimmune activities. You can use plasmapheresis. Plasmapheresis is nothing but taking patient's blood out of the body, filtering it. Filtering it for what? We will filter it for, basically it will filter all the plasma proteins, but it will filter all the antibodies basically. Antibodies are also kind of plasma proteins on, right? Immunoglobulins. So what this plasmapheresis will do, because of our body is having so much antibodies to our own cell, autoantibodies, we just need to filter it out. So when the plasma again comes back to our body, it will get filtered and there will be reduced amount of antibodies in our body. Okay, and when they are returning to our body, we have to add 5% albumin to that, because even albumin would have got filtered. Okay, so we have to do it 3 to 4 times a week, and one cycle every 4 weeks we need to. Right. So if this week, or that is basically in every month one cycle we have to do, and in one cycle there will be 3 to 4 times of plasmapheresis in a week. Okay, so is this plasmapheresis clear to everyone?
Yes, sir.
Okay, Bhavna, is it clear to you? Everyone able to hear me?
Yes, sir. Yes, sir.
Okay, this is clear to everyone, right?
Yes.
Let's move on to the next topic. That is paraneoplastic pemphigus. So this is basically pemphigus only, kind of pemphigus only. But it is called paraneoplastic pemphigus because 2 things. Etiology is different and it is associated with neoplasms. Why is etiology different? Paraneoplastic pemphigus, in this antibodies are generated from the cancer cells or from the cancer or the tumors that are there within our body. They'll increase the amount of antibodies forming, leading to the lesions. Okay, so this paraneoplastic pemphigus usually is associated with the non-Hodgkin's lymphoma, the CLL, as well as the Castleman disease. These are the 3 main cancers which leads to the this paraneoplastic pemphigus. So what will happen? This malignancies will be having certain antigens. Okay, so this antigens will stimulate generations of antibodies. This antibodies will cross-react with the epithelial proteins, leading to epithelial breakdown. That is what is paraneoplastic pemphigus. Otherwise, everything is same as our regular pemphigus that we have discussed. Okay, so it will lead to painful erosions. The sites will include oropharynx, lateral border of the tongue, permeate border, all the oral cavity basically, and it can include other mucosa such as our conjunctival involvement will be seen as well, and the cutaneous lesion, which are variable and they are more polymorphic than the regular pemphigus vulgaris. Diagnosis is based on the criteria major and minor. Major criteria is there has to be polymorphous mucocutaneous eruptions. concurrent internal neoplasia has to be there, and there has to be specific serum immunoprecipitation patterns. And minor criteria will include histological evidence of the acantholysis. Direct immunofluorescence should show intracellular and basement membrane staining, and the indirect immunofluorescence staining should with the red bladder should show positive. Okay, so here the diagnosis is basically same based on the histopathological investigations. In the direct immunofluorescence of this paraneoplastic pemphigus, the IgG deposits both intracellular space, that is intracellular between the two cells, as well as the junction of the dermal and epidermal part, that is the basement membrane. Both of the part will be seen stained. Okay, and the basement membrane zone deposit of the IgG and competent components may be observed in this paraneoplastic pemphigus. In the indirect pemphigus or the indirect immunofluorescence, that is for the pemphigus vulgaris, it was done on the monkey esophagus. For the paraneoplastic pemphigus, we are doing it on the rodent bladder or the bladder mucosa operandi, which is the transitional epithelium. It is used as additional substrate in addition to the monkey's esophagus, because the paraneoplastic pemphigus binds to simple columnar, transitional, and stratified squamous epithelium, whereas the pemphigus vulgaris antibodies, they bind to the stratified squamous epithelium only. Are you getting this point here? Pemphigus vulgaris, in the direct or the indirect immunofluorescence test, we use the patient's serum on the monkey's esophagus. Now this monkey's esophagus is having the columnar cells only, right? The desmoglein between the columnar cells are affected in the pemphigus vulgaris. But in case of the paraneoplastic pemphigus, the antibodies are also against the transitional epithelium desmosomes. So the transitional epithelium, as we know, is usually seen in our urinary tract. Okay, so we cannot take our own urinary tract epithelium for the investigation. So we use the bladder of the rat for this investigation. So for the diagnosis of the paraneoplastic pemphigus, the indirect immunofluorescence should be positive on the monkey esophagus, but it also should be positive on the rat's bladder also. Then only the diagnosis will be confirmed. Is it clear to everyone? Yes? If it is clear, you have to just answer me in between, so I know that you guys are listening. Is it clear?
Yes, sir.
Yes, sir.
Okay. So let's move on to the next topic, that is mucous membrane pemphigoid. The first two we saw pemphigus. Pemphigus is intraepithelial lesions, lesion within the epithelium. The pemphigoid is affecting the basement membrane. Now here, in the pemphigus vulgaris, the proteins which were affected by desmosomes, that is the connecting a cell to another cell. In the pemphigoid, hemidesmosomes are affected, that is the proteins that are connecting the epithelium to basement membrane. So in the mucous membrane pemphigoid or any other pemphigoid, there will be detachment of the epithelium from the basement membrane. Getting? If this is the basement membrane, this is epithelium, and this is our basement membrane. In the pemphigus, the lesion is on this area. Within the epithelium, the cells to cell detachment is there. But in this case, the epithelium and there is this basement membrane, this is epithelium, and this is our basement connective tissue. So there will be detachment of the epithelium from the connective tissue or from the basement membrane like this. So this subepithelial split will be seen in case of the mucous membrane pemphigoid. So this mucous membrane pemphigoid belongs to a group of mucocutaneous subepithelial bullous dermatosis. It is usually 7 times less than the bullous pemphigoid. It affects women more than men, and age for both the pemphigus and pemphigoid is more than 50 years, triggered by the medications. Okay, so condition is same only. The defect in the immune system will go, that is our autoantibodies, they'll go and act on the basement membrane zone proteins. Now, which are these basement membrane zone proteins? That is basically the ones which are affected as, see, remember, this antigen itself is known as bullous pemphigoid antigen, BPAG, BPAG1, BPAG2. Along with that, we have the laminin. So BPAG1, BPAG2, and laminin are the main components of the hemidesmosomes which are affected by our autoantibodies in case of the bullous pemphigoid. So BPAG1 is basically intracellular protein, BPAG2 is transcellular protein that is going through and through of these cells. And our laminin 5 is basically the one which connects or basically what it does, it is major ligand between the anchoring fibrils and laminin 5. So this BPAG2 is connected to the connective tissue with help of this laminin 5 and the anchoring fibrin. So as I told you, in the pemphigus, what was happening? The cell-to-cell attachment was being affected or were being attacked by the antibodies. Whereas in case of the pemphigoid, the cell to the basement membrane connection which are there, they are being affected by the antibodies. Right? That is the difference between them. So autoantibodies produced in the mucous membrane pemphigoid target several of the different components of the basement membrane zone, that is BPAG1, BPAG2 and the laminin 5. Clinically, what you will see, extraoral and intraoral manifestation, both of them are there. Extraorally, you will see lesion on the skins of the oral cavity as well as palms and the other body parts. Lesion can also affect stratified squamous epithelium of eyes, larynx, subglottis, esophagus, nose and our genital regions. In the eyes, it begins as a chronic conjunctivitis that will ultimately lead to irritation, photophobia and excessive tears. Now, because of all these lesions are going on, continuous inflammation is going on, or what it will do, it will lead to fusion of the sclera to the conjunctiva. The sclera and conjunctiva are usually separate. You can separate them like this if you separate it. But in case of this mucous membrane pemphigoid affecting the eyes, our sclera and conjunctiva will become fused to each other. You will not be able to separate it like this as you are able to do it now. This condition is known as symblepharon. Fusion of sclera and the palpebral conjunctiva is known as symblepharon. And whenever there is fusion of superior and inferior palpebra, when the superior and inferior palpebra, as we are able to move them separately, when they join with each other because of this condition, we call them as ankyloblepharon. Get this point? What is difference between symblepharon and ankyloblepharon? Anyone? What is happening in skin? Symblepharon. What is happening in ankyloblepharon? Can anyone answer?
Fusion of scleral and conjunctival.
Fusion of sclera and conjunctiva in case of the symblepharon. And in case of ankyloblepharon, what will be there? There will be fusion of the palpebrae. Right? That is seen in the ankyloblepharon. Superior and inferior palpebra, when they fuse together, this is ankyloblepharon. They joining with each other. Patient not able to open the eyes. That is ankyloblepharon. When our conjunctiva, that is palpebral conjunctiva, gets attached to the sclera, that is known as symblepharon. Is this difference clear to everyone? Symblepharon and the ankyloblepharon?
Yes, sir.
Yes, sir.
Okay. Oral cavity, what you will see? Positive Nikolskin. Remember, Nikolskin is positive for the mucous membrane pemphigoid, not for the bullous pemphigoid. Okay. So it will be positive for the mucous membrane pemphigoid. You will see blisters when they rupture. It will lead to irregularly shaped erosions with the yellowish slough surrounding the inflammatory halo. Discriminative gingivitis of the gingiva will be seen. There will be loss of stippling, extending apically from the gingival margin till the alveolar mucosa. Loss of stippling will be seen, and there will be delayed and incomplete healing following the periodontal treatment will be seen. Okay, these are the findings clinically in the oral lesion of mucous membrane pemphigoid. How we are going to treat, diagnose it? Clinical examination and biopsy. Again, we have to do biopsy with the two specimen. The first specimen is of the lesion, that is the histopathology, that we will see suprabasilar cleavage or subepithelial blister formation. We will be able to see this mechanism. I already told you that in the mucus or in the pemphigus we were seeing intraepithelial blisters. In the pemphigoid we are going to see subepithelial, that is below the epithelium, or you can say suprabasilar, above the basement membrane. The cleavage will be seen, which will have chronic inflammatory infiltrate. And the second specimen, we have to do immunofluorescence, direct and indirect. In the direct immunofluorescence, what you will see? Uniform apple green linear deposition of the IgG along the basement membrane zone. And indirect immunofluorescence, it will detect the autoantibodies present in the patient's serum. Circulating antibodies are seen more commonly in the bullous pemphigoid. Now, what is this appearance of the mucous membrane pemphigoid? So, as we had seen in the pemphigus, what was there in the pemphigus? This fluorescence was seen here as a fishnet appearance because the antibodies were between the cells. Okay, this is epithelium, and this is connective tissue, and in between this part is our basement membrane. In the pemphigus, because the antibodies were present in the epithelium, so because of that, between these cells, the antibodies were there. We were able to see the fluorescence here. That appearance was known as, in the pemphigus, it was known as which appearance?
Fishnet appearance.
Yes, it was
Fishnet appearance.
fishnet appearance in the pemphigus. But in case of pemphigoid, mucous membrane pemphigoid, we don't see that. Here, there is linear deposition of the IgG at the basement membrane. Got this point? That is the clinical finding of, the immunofluorescence finding of immunofluorescence differentiating between the pemphigus and pemphigoid. Who will quickly tell me the difference between the immunofluorescence finding of pemphigus and pemphigoid? Yes, Madhu, can you tell me? Shubham?
Sir, there will be like fishnet appearance in pemphigus, and in pemphigoid there will be linear deposition of
Linear
fluid.
deposition. That is, of course, and yes, and that very good. And that is based on the distribution of our antibodies as they are distributed, right? Now, the next condition, we can talk about the bullous pemphigoid. We can talk about the linear IgA disease. Now, this mucous membrane pemphigoid, as I told you, is having linear distribution. Linear IgA disease has same linear distribution. Bullous pemphigoid has same linear deposition, as well as epidermolysis bullosa, that a hereditary condition that we discussed in the beginning. All of them have the deposition at the basement membrane. Now, in this case, it becomes difficult with help of the immunofluorescence to find out whether it is, whether it is pemphigus or pemphigoid, you can find out based on immunofluorescence. Then it is fishnet appearance is pemphigus, linear deposition is pemphigoid. But now, next, so many conditions with linear deposition, how we are going to differentiate between them? At that point, there is a test which we can use is salt split test. What do we do in salt split test is, we put the skin in the salt solution, 1 mole per liter sodium chloride solution. So when you put it there, what it will be there? There will be separation of the layers of skin, the epidermis and the dermis, right? Or you can say the epithelium and the connective tissue will get separated from each other. There will be separation between them. So this epidermis or the epithelium from the connective tissue will be separated from each other at the lamina lucida of the basement membrane zone. Basement membrane has 2 parts, lamina lucida and lamina densa. So epidermis from the connective tissue will be separated from each other at the lamina lucida. Now the antigens of the basement membrane zone are exposed, improving sensitivity for the detection. So what happens is, if this is the epithelium and this is the connective tissue, okay, if it was pemphigus, the antibodies were in this part only, it was easy to diagnose. But in case of the different kind of pemphigoid and linear IgA disease and all the antigens are in this area only, so we'll not be able to diagnose. But now what happens? This basement membrane zone itself is separated into 2 parts. The lamina lucida is here, lamina densa is here. Two separate part of the basement membrane zone are separated with help of the salt solution. That is salt splitting of the skin with help of the salt split procedure. Now, when you do immunofluorescence in them, what will happen? If you see the this immunofluorescence on the roof side, that is on the top side of the basement membrane, that is the antigens on the epidermal side towards the lamina lucida, that condition is mucous membrane pemphigoid or bullous pemphigoid. Now, this mucous membrane pemphigoid and bullous pemphigoid can be differentiated clinically also. So even if both of them are coming as a result, we can diagnose based on clinical. And if you are seeing the immunofluorescence on the floor side, it is known as, the condition is epidermolysis bullosa acquisita. That is, the antigens are on the dermal side of the skin. How we are going to know whether they are on the dermal side or epidermal side? Here also we'll do immunofluorescence. So what we'll do, this is the intact skin, as you can see here. When you put this in the let's say salt, it will differentiate in the roof and the floor. Roof is epidermis, floor is the dermis. On the roof side, if you see immunofluorescence in this pattern, the roof pattern is seen in which lesions? Bullous pemphigoid and mucous membrane pemphigoid. And if you see this distribution on the floor side, it is epidermolysis bullosa acquisita. Is it clear to everyone, the salt split test?
Yes, sir.
Yes, sir.
Okay, so here you can see this immunofluorescence test done on the skin of a patient. Now here you can see the floor pattern. Now if you see closely, this is the basal membrane zone which is separated between each other. So what you can see here, the immunofluorescence is on the top side, or you can see roof pattern of the immunofluorescence, and here it is on the downside, that is the floor pattern. So who will tell me which one is this? The roof pattern is seen in which conditions?
Bullous pemphigus.
Bullous pemphigoid and
Mucous membrane.
mucous membrane
Mucous
pemphigoid. And this floor pattern we will see in
Epidermolysis bullosa.
right. Very good. So that is how we can diagnose with help of the salt split test. Okay. So that is about the mucous membrane pemphigoid. Next we are going to discuss about the bullous pemphigoid. Bullous pemphigoid is also almost same kind of pemphigoid, but here the antibodies are more affecting toward the skin as compared to the mucous membrane. Skin will be most commonly affected. You will see bulla or larger shape bulla appearing in the skin with the erythematous base when the bulla gets ruptured, and it will lead to ulcer and scarring formation. Okay. On investigation, what you will see, 3 investigation will do. One specimen, first specimen will do biopsy, and the regular investigation that will show suprabasilar split. First thing. Second specimen will use for the immunofluorescence test. Immunofluorescence, it will show to us what? Direct immunofluorescence and indirect immunofluorescence, most of them will be positive with linear IgG deposition. Now this linear IgG deposition is there in the bullous pemphigoid also, in the mucous membrane pemphigoid also, in the EBA also. Whether it is bullous pemphigoid or mucous membrane pemphigoid, we were able to diagnose based on our clinical finding also. But whether it is linear IgA, whether it is epidermolysis bullosa or a bullous pemphigoid, that we have diagnosed based on this findings, right? With help of these findings, we can find out that in this case, in the salt split test, where will be the staining of the basement membrane seen? Anyone?
Roof pattern.
Where?
Roof pattern.
Yes, we'll be able to see that in the roof, as you can see in this. Can you see here? This is the roof pattern that we are seeing over here. Next, we are going to see the differential diagnosis. Pemphigus vulgaris can be classified based on Pemphigus vulgaris and Bullous pemphigoid. Clinically itself you can classify, otherwise you can do the other investigation. Benign mucous membrane pemphigoid can be differentiated with the Bullous pemphigoid based on the skin involvement or not. Epidermolysis bullosa can be differentiated from the Bullous pemphigoid based on which finding? Based on salt split test, the roof and floor pattern. Okay, and Erythema multiforme based on the clinical findings, again you can differentiate. The treatment is basically we have to reduce the inflammatory response with help of the anti-inflammatory agents such as corticosteroids. You can also give tetracycline or dapsone for the same, and we have to be immunosuppressants such as steroids again, or steroid sparing drugs such as azithromycin, methotrexate, the mycophenolate, mofetil, as well as cyclophosphamide. Okay, so these were the vesiculobullous lesion autoimmune. The last one we are going to discuss about is erythema multiforme, which is a blistering ulcerative mucocutaneous condition. Now this condition you can differentiate from this pemphigus and pemphigoid based on the presence of crusting on the skin. Okay, with help of that you can differentiate when it is in the ulcerative phase. Otherwise, there are other features also such as target lesions on the skin and all those things that we are going to discuss now. Bullous lesion. Now, erythema multiforme can be classified as erythema major and minor. And previously, it was described that when it becomes severe, it was Stevens-Johnson syndrome and toxic epidermal necrolysis. But now it is shown that they are not this one and same; they are the different conditions itself. So, erythema major is a severe form of erythema multiforme, where you will see involvement of 2 or more mucous membrane with skin involvement. Whereas in the erythema minor, there is no more than one mucosa affected with it may or may not involve the skin. So etiology is first is genetic predisposition. By genetics, a person will be predisposed to this erythema multiforme, and then certain agents, mycoplasma, HSV, certain drugs, fungal infections as well as parasites. All these infectious origins can lead to onset of erythema multiforme. But remember one thing, the agent most commonly associated with erythema multiforme, microbial agent most commonly associated with the erythema multiforme is going to be mycoplasma. Remember this, okay? Mycoplasma is most commonly associated agent with the erythema multiforme predisposition. And then you can have certain food additives, immune conditions, or drugs which can lead to the precipitation of erythema multiforme. All this anticonvulsants, barbiturates, sulfonamides, cephalosporins, steroids, as well as certain NSAIDs can also lead to the predisposition of our erythema multiforme. Okay, so when we talk about the herpes simplex associated erythema multiforme, what happens? Our HSV DNA that is present in our skin or mucosa being latent, then when it precipitates the disease, it will lead to ultimately formation of certain antibodies against our skin molecule that will go and affect the cytokines and chemokines that will recruit the T cells in the particular area, that will bring in the cytotoxic T cells, leading to cell damage that will lead to the this particular lesion formation. Same way as did the HSV virus, same way drugs also can lead to inflammatory reaction in that area, leading to cell death, leading to lesions. Clinically on the skin, you will see typical lesions, that is the target lesion, as you can see here, a bullseye lesion that will be round in shape with well-defined border. There will be 2 concentric palpable edematous rings that you can see with the center pale area in this target lesions. This target lesion has central dark or red area, that is here, surrounded by the pale pink or edematous ring zone, and the peripheral ring zone can be seen. That is a typical target lesion. You can see certain atypical lesions also, such as palpable erythematous lesions within round shape, as you can see here, with poor defined borders, and you can see dark central area which erode and become necrotic as well. Then you have flat atypical lesions. So this one's the atypical lesion. Here we saw the raised atypical lesions. These are the flat atypical lesions. The tendency for the center blister formation is there. They are not palpable. And there are certain erythematous macules also, which can be seen in case of erythema multiforme. Orally, the lesions will range from the mild erythema to the painful ulcers in the tongue and labial mucosa. Right? Here you can see the clinical findings of the erythema multiforme. In the erythema multiforme minor, skin lesions are distributed symmetrically on the external surface. In erythema major minor, there will be involvement of the multiple mucous membrane also. Now, the textbook of Burkitt for oral medicine, it also mentions a third type of erythema major, that is erythema major exclusive of the mucous membrane or exclusive of the oral mucosa. That also will have lesions being same. Diagnosis is based on histopathological investigation. You can find out inflammatory infiltrates surrounding the swollen blood vessels. Papillary dermal edema will be there. There will be vacuolar degeneration of the basal layer, and there will be subepidermal blisters will be seen. We don't have to do immunofluorescence in these cases. They can be classified or the diagnosed based on the other findings also. Okay. Management is usually we have to treat the supportive care measures, and moderate to severe cases require specific therapies as analgesic. We have to use, in case of severe cases, we have to use steroids also for the treatment in these cases. And then we have if it is HAM, that is herpes simplex associated erythema multiforme, we can use acyclovir as much as 800 mg BD for 10 days. Okay, use of corticosteroids as such is controversial, but we can give them and then we can taper it to the regular dose. Other steroid-sparing drugs are dapsone, azathioprine that we can use. A severe form of this previously as it was considered, but now considered a separate disease, that is Stevens-Johnson syndrome and toxic epidermal necrolysis. So there is recurrent evidence which suggests that epidermal, this erythema multiforme, SJS and TN, Stevens-Johnson syndrome and toxic epidermal necrolysis, they are not the same continuum of a spectra, but they are separate condition. Stevens-Johnson syndrome is a minor form of this with less than 10% body surface involvement. Toxic epidermal necrolysis is when the skin involvement is more than 30%, around 25 to 35%. It affects women more than the men, almost 1.5:1 ratio. Patient groups, particularly at the risk of immunocompromise, at the risk are immunocompromised such as HIV and lymphoma. The patient with the brain tumors undergoing radiation therapy and receiving anti-epileptics, they are more prone to SJS and TEN. The therapeutic drugs such as antibiotic, NSAIDs, anticonvulsants can lead to Stevens-Johnson syndrome in 50% of the cases. And whenever it is toxic epidermal necrolysis, almost 80 to 95% of the cases are after the treatment with either antibiotic or NSAIDs or anticonvulsants. The infections and immunizations, you can, this 10% mycoplasma is again same as the erythema multiforme. Here also the mycoplasma is associated with these cases. So what will happen here? There is impaired capacity to detoxify the reactive intermediate drug metabolite in our body, in those who are genetically predisposed to SJS and TEN. So what will happen? There will be this drug metabolite will stay in our body rather than getting metabolized. So they'll lead to immune response, and our antibodies will act on them as antigen, leading to the cell death in that area, leading to the lesion formation in the Stevens-Johnson syndrome and the toxic epidermal necrolysis. Here you can see the findings, clinical findings in them. You can see flat, stingy, raised pink spots, raised or spread throughout the body. Right? The skin lesion appear on the trunk and spread to the neck, face, and proximal extremities. Here also it is kind of centrifugal growth from the center towards the periphery. The involvement of the respiratory tract as well as GI tract can be there, that will lead to decreased intake of the food by patient. Sometimes you have to give them hydration support from the IV. Here you can see extensive involvement of the face, extremities, of the eyes, and of the oral cavity also. Okay, this Stevens-Johnson syndrome and toxic epidermal necrolysis clinical findings. Diagnosis, early diagnosis is requirement for the treatment. For the first thing, we have to stop the agent which caused the thing. If it is due to a drug, we have to stop the drug and we have to give the specific supportive therapy along with the specific therapies such as cyclosporine, cyclophosphamide, corticosteroid. Here again it's controversial, but it is used. Plasmapheresis and IVIG, that is intravenous immunoglobulins, can be used. Like linear IgA disease, here again there is deposition of the antibodies at the epidermis, but the antibody that is causing this condition is IgA. The cause is unknown, and but these cases are mostly drug induced, and the most commonly drug which is causing this disease is vancomycin. So remember, this can be asked to an exam, that which drug is causing linear IgA disease. The answer will be vancomycin. Which, as the name suggests, which antibody is associated with the linear IgA disease? The antibody is going to be immunoglobulin A, and the antigens associated with them are heterogeneous, found in lamina lucida as well as lamina densa of the basal membrane zone. Clinical features: there will be periods of the pruritus, then the skin lesions will appear, there will be hemorrhagic round vesicles, and the other manifestations will be macules, papules, and erythema multiforme like eruptions. Okay. The oral lesions is seen in 70% of the cases. The erosion and blisters on mucosa, they are having the desquamative gingivitis as well. In the laboratory finding, you will see subepithelial blister with rich inflammatory infiltrate. There will be linear deposition of the IgA at the dermal epidermal junction. The 80% of the children and 30% of the adults will show IgA within the body, with the antibodies towards the epidermis on the roof side of the salt split. If we are going to do again, based on the serum antibody, we can find out it is IgA is more likely to be linear IgA disease as compared to the other roof pattern conditions such as Bullous pemphigoid and Mucous pemphigoid. And the last one is epidermolysis bullosa, which is a hereditary condition where you will see from the child or from the birth also or at the younger age, it is autosomal dominant. It is seen usually at the sites of trauma, which will heal within 2 to 10 days. And the bullae of the oral cavity are rare in this condition. Okay, it can be classified into hereditary and that is epidermolysis bullosa, that is hereditary. Epidermolysis bullosa dystrophic dominant and epidermolysis bullosa acquisita. These are the types that are classified. The acquisita one is important, that is EBA, that is bulla formation on the minor provocation. The blister may result in scar and atrophy of the area. There is restricted oral orifice because there are multiple scar formation at the angle of mouth, right? And they'll also have hypoplastic teeth in these cases. Here, the subepithelial blistering disease is there, and it is usually on the type 7 collagen of the anchoring fiber where the antibodies are acting upon. The subepithelial blisters, this disease here, the tissue bound and circulating antibodies at the dermal to epidermal junction. In this area, it is seen. Pathophysiology, type 7 collagen are the main constituents of the anchoring fibrils, which are identified as antigens, and IgG deposits are found in the sub-basement membrane. Okay, clinically you will see inflammatory and non-inflammatory phenotypes. There will be extreme fragility of the skin. There will be trauma-induced blisters and erosions, which will be seen, and the oral lesion will be same as mucous membrane pemphigoid and bullous pemphigoid. The only difference between them is the salt split test will show the involvement on the floor side as compared to the roof side. Okay, so this we have covered the skin and vesiculobullous lesion in this topic. Anyone is having any doubts from the skin and vesiculobullous lesion topic? No, right? Okay. So what we will do here is we'll have a 5 minutes break again, and then we are going to start with the next topics, that is red and white lesions. Okay. So you can have 5-10 minutes break, and then we'll continue in the same session. You can continue. You don't need to. If you are on YouTube live, you can continue there. If you are on our app, you can even close your app and you can come back on the same session. It will be available here. Okay. See you all after 5 minutes. Hello everyone. So let's resume with our next session, that is red and white lesions of the oral cavity. All ready? Hello, everyone able to hear me? Am I audible to everyone? Hello, am I audible to everyone?
Yes, sir.
Yes, sir.
Hey, you guys are not answering, then how will I know that I'm audible or not? Okay. So, yeah, let's start with this session on red and white lesions of the oral cavity. So, first of all, the color of oral mucosa usually is pink in color, the ginger being coral pink. Now, the color being more white or more red depends on certain factors. First is blood vessels. The more the blood vessel or more the vascularity, the more the reddish the color of a mucosa. Degree of keratinization. More the keratinization, the skin will become more white. Lesser this keratinization, the skin will become more red. Amount of melanin pigmentation in the epithelium also will determine the color, and the thickness of the epithelium will also determine. Okay, so our oral mucosa, when there is a white lesion, it will appear white because of certain reason. Well, first is hyperkeratosis. So if this is our skin, we know this is epithelium, and above the epithelium there is keratinization. So if there is more keratinization in this area, this will lead to skin appearing more, you can say, whitish. Okay, when there is acanthosis means increase in the number of cells in the epithelium. So when there are increased number of cells within the epithelium, the skin again will appear whitish. Whenever there is accumulation of the fluid within the epithelium, the skin will appear white. Necrosis of the epithelium. Whenever there is necrosis, there will be presence of you can say pseudomembrane over the epithelium. For example, let's say acute necrotizing ulcerative gingivitis, or any other condition where there is a pseudomembrane formation over the skin, the lesion will appear white. And whenever there is reduced vascularity, for example, OSM, in the OSM, if the vascularity of the skin or the area is so reduced, it appears more pale or on the whiter side. Now, same way here you can see increased keratinization of the skin, increased number of cells, increased accumulation of the fluid, and presence of the pseudomembrane. All of them will lead to whitish appearance of the skin. And the skin will appear reddish because whenever the epithelium is thin, atrophic epithelium, as you can see, will lead to redness of the skin. Or whenever there is reduced the number of cells, the atrophy of the skin will be there. Whenever there is increased vascularity, it will lead to reddish appearance, or you can say reddish pigments from the increased hemoconcentration. All of them will lead to skin appearing red. Now, this classification can be based on acute or chronic, localized or generalized, developmental or pathological. In general, you can say red with keratotic, red with necrotic, or vesiculobullous lesion. All of them are red lesions. Okay, we are going to see them one by one, white or red lesion based on the origins. So let's discuss about red and white lesion based on the infectious origin. So that is Candidiasis and hairy leukoplakia. Now, Candidiasis we know that is infectious origin. Can you tell me what is hairy leukoplakia? It is seen in which infection? Anyone?
So leukoplakia is a whitish patch in the oral cavity which cannot be scraped off or peeled off easily. And when
that is leukoplakia. We are talking about hairy leukoplakia. Hairy leukoplakia is an infectious disease or a condition that is seen due to infection. In which infection do you see hairy leukoplakia? Anyone?
HIV associated.
Yes. In the HIV infection, you'll be able to see hairy leukoplakia on the lateral surface of the tongue. That is hairy leukoplakia. Okay, so leukoplakia and hairy leukoplakia are two different things. Leukoplakia is a precancerous or a premalignant condition associated with its own etiology that we are going to discuss next. Hairy leukoplakia is one of infectious origin we are going to discuss in the next session. First is candidiasis. Now this candidiasis, also known as moniliasis or thrush or candidiasis, it is an opportunistic infection which affects the oral mucosa. It is caused by yeast Candida albicans, and the predisposing factors that convert the Candida from the normal commensal saprophytic phase to the pathogenic organism. So Candida as such is there in our oral cavity. You and me who don't have candidiasis, we also have a presence of Candida albicans in our body. But any organism, or let's say this fungus, has two phases: saprophytic phase and parasitic phase. Saprophytic phase means it is there in our body. It is taking, you can say, nutrition from our body, but it is not causing any harm. That is commensal flora, saprophytic. But there are certain factors which will make it parasitic. Parasitic means it will cause harm to our body without helping us in any ways. That is parasite. So the factors, the predisposing factors, convert the Candida albicans from the saprophytic phase to the parasitic phase. So which are these factors? Either local or generalized factors. Local factors, the first and foremost is poor oral hygiene. So when you are smoking or when you are wearing denture and not doing regular hygiene practice, this along with the topical steroids leads to decreased immunity, or inhalation steroids. All of them will ultimately lead to increased growth of Candida from the saprophytic to parasitic phase, leading to candidiasis. And so these are the local factors. We have the systemic factors also. So immunosuppressive condition or immunosuppressive drugs will lead to this condition. Also, long-term antibiotics can also cause candidiasis. Why? Because the antibiotics that we are using, they are going to kill the bacteria that are there in our oral cavity, even the commensals. So in our oral cavity, we have commensal bacteria, we have commensal fungi, that is candidiasis. Both of them are in you can say in a competition phase, or they are there controlling each other's growth. Now when we give the antibiotic, the bacteria will die. So this Candida has no one to compete with. It can grow easily. That will lead to infection, right? So these antibiotics, along with the other condition that I told you, are going to cause the oral candidiasis. So all this predisposing factor will convert the bacteria from the saprophytic phase to the parasitic phase. Remember, this can be asked in an exam, that the predisposing factors makes the commensal flora candidiasis, Candida albicans, to cause candidiasis in our oral cavity. During this phase, the Candida is converted from dash. The options will be parasitic to saprophytic, saprophytic to parasitic, and all the other options. The answer will be, what will be the answer?
Saprophytic to parasitic.
Saprophytic to parasitic.
It will convert the flora from the saprophytic to the parasitic phase. Okay, so most common species causing the oral candidiasis are Candidus albicans, tropicalis, and glabrata. Most common one is albicans, which is causing this condition. Okay, now this candidiasis can be classified as primary candidiasis and secondary candidiasis. Primary candidiasis means what is the difference between primary and secondary? Primary means the organism or the oral Candida albicans themselves cause the disease in a person, in which there was no other systemic condition which led to the susceptibility. But in the secondary candidiasis, our overall condition is such which can lead to more Candida growth, leading to more infection. So primary candidiasis in the acute phase has pseudomembranous and erythematous condition. In the chronic phase, it has pseudomembranous, erythematous, as well as plaque-like condition. And certain Candida associated lesion can be there, which is denture stomatitis, angulocholitis, and median rhomboiditis. We are going to discuss them one by one. So pseudomembrane candidiasis, also known as oral thrush, the most common type of candidiasis that is seen on our oral cavity, which you can, or on the tongue, which you can scrape off with help of the tongue blade or any other thing. So its acute form is recognized as classical Candida infection, which affects the patients medicated with antibiotics and immunosuppressants. Why? I told you just now. The oral lesions are soft, white, and elevated plaques, which are you can describe to them as curdly white plaques, which can be wiped off easily. The clinical presentation of acute and chronic of pseudomembranous candidiasis is indistinguishable. Only based on history you can know whether it has just occurred recently or it has been a long-term problem of a patient. That we can classify based on you can say this history. Acute one will be recent, chronic one will be of long-standing case. Otherwise, both of them appear clinically they are same. The chronic form usually is associated with the HIV infection and the steroid inhalers. The steroid inhalers usually what remember the site specificity is also there. If a person is steroid inhaler, that means they'll be using pump. Now, can you tell any condition who uses steroid to inhale?
Bronchial asthma.
Right? In those cases, they might be inhaling the steroids. So those cases, the steroids directly goes on the palate, and on the palate, the area where the steroid is there, that particular area there will be you can say a localized form of immunosuppression. The immunity in that area will go down, leading to more growth of Candida in that region, leading to lesion of the palate. Okay, so here you can see the pseudomembranous form of Candidiasis on the lip, on the angles of the oral cavity, on the buccal mucosa, on the palate region, right? This kind of region on the posterior part of palate you will see usually on those who are using pump for the steroid inhalation. So that was pseudomembranous candidiasis. Pseudomembranous means on the epithelium there is another pseudomembrane is there. Pseudomembrane. Then you have erythematous candidiasis, also previously called as atrophic candidiasis. Now this kind of candidiasis causes the reduction in the thickness of the oral epithelium. Pseudomembranous candidiasis is not reducing the thickness, but it is having the pseudomembrane over the epithelium. But the erythematous candidiasis on the other side is reducing the thickness of that particular epithelium, that is called as atrophic candidiasis. Now this condition is more commonly seen in those who are using long-term antibiotics. That's why its other name is antibiotic sore mouth or antibiotic stomatitis. It occurs as a sequel of course of broad spectrum antibiotics. Also, it is seen in inhalation steroids and smoking conditions. Here, the lesion is red or erythematous, can occur on any side in the oral cavity, and this is the only variety of the oral candidiasis which is constantly painful. This pseudomembranous candidiasis, if the patient is unhygienic and not aware much of the oral hygiene, they won't even notice that there is this condition present in the oral cavity because it is non-painful. Whereas the erythema candidiasis, it is painful condition. Okay, and the only variety of candidiasis which will be painful. Here you can see this lesion here on the tongue, on the palate, right? Here on the midline of the palate, this condition is there. Now, this candidiasis, which is there on the palate, can spread to the that is there on the tongue, can spread to the palate also. For example, let's say there is atrophic midline candidiasis of the tongue on the posterior side. If when it constantly stays in contact with our palate from the tongue, it will get transferred to the palate. Can anyone tell me what this condition is known as?
Kissing lesion.
Yes?
Kissing lesion.
Yes. It is known as kissing lesion. What happens is, let's say this is our tongue and this is our palate. So obviously when at rest, our tongue constantly stays in contact with the palate also. So whenever there is candidiasis of the tongue region, when it stays constantly in the contact with the palate, the candida present on the tongue will get transferred to the palate, and on the palate also they will cause this condition. This is known as kissing lesion. There is another condition known as kissing disease. Can you tell me what is kissing disease?
Infectious mononucleosis.
Yes, this is kissing lesion. Then we have kissing disease also. This kissing disease is infectious mononucleosis. This infectious mononucleosis is caused by which virus?
Human papilloma.
Which virus it is? Epstein-Barr virus. Epstein Barr virus will cause this condition. Okay. Then the third type is plaque type of oral candidiasis. Plaque type means, see, first we saw pseudomembranous. That means on epithelium there is presence of a pseudomembranous. Then we saw atrophic candidiasis where there is no pseudomembrane but epithelium itself is reduced in thickness. Then we have plaque type where thickness of epithelium is increasing, also known as chronic hyperplastic candidiasis. It is called Candida leukoplakia also because it will appear as if it is same as leukoplakia. It is characterized by a white plaque. It is also considered to be a premalignant condition. It has been associated with malignant transformation from the candidiasis, or this plaque type candidiasis can get converted into the malignant condition. Okay, here you can see nodular or hyperplastic candidiasis. Okay, then we talk about the candida associated lesions. The lesions which are associated with candida but not directly associated with it. First is denture stomatitis. So the patient, when those who are wearing the maxillary denture and they don't clean it properly, it will lead to lesion on the area below the denture. Now, one thing you have to remember, this denture stomatitis is very rare in the mandible denture area. It is very common in the maxillary area only. The mandible area is self-cleansing because the salivation is there. It will keep on cleaning that area, so that won't be an issue. Okay. Now, this denture stomatitis or candida associated lesion is classified into three types: type 1, 2, and 3 by Newton. Now, Newton classified the denture stomatitis into three types. First is when there is localized minor erythematous signs, a pinpoint lesion, that is type 2. Type 2 is when it affects a major part of the denture covered area, and third is when it has a granular mucosa. Type 1 and 2 can be treated with the medications, but for type 3, you have to surgically excise the granular mucosa. Okay, that is stomatitis. Second is angular cheilitis, that is characterized by erythema and fissuring and scaling at the angles of the mouth. Here, the saliva tends to pull in, keeping the area moist and favoring yeast infection. So ultimately, the candidial infection will involve this area, creating the pattern. So what you can see here happen, because there is constant pulling of the saliva in that area, it will lead to angular cheilitis. Now, angular cheilitis is a condition. It is not ideally just, you can say, due to or a primary fungal infection. There are multiple causes which can lead to angular cheilitis. Which are these causes? First is vitamin deficiency. B12 deficiency can lead to angular cheilitis. Second thing is this fungal infection that we just now saw. Third is the denture wearing patient, when the vertical height is reduced. When the vertical height is reduced, there is constant folding of the angle of mouth, where the saliva will be pulled, and that area will be causing infection in that area, leading to candidial infections. And then there is chelocandidiasis, that is candidial infection of the lips. That is a diffuse form of chronic candidiasis, which is characterized by pain, swelling, erythema, ulceration, and tusking of the lips. Okay. Then we have median rhomboid glossitis. Now, median rhomboid glossitis, as such, there are two sort of schools. One says it is a one says it's a developmental condition that is present since birth, and second says it's of a candidial or infectious origin. Okay. Now, it has been established that this condition is you can say infectious origin. Okay. So it is characterized by erythematous lesion in the center of the posterior part of the rostrum of tongue. It has an oval configuration resulting in atrophy of the filiform papillae. Smokers, denture wearers, and inhalation steroids, those who are using it directly on the tongue, will have this condition. This is asymptomatic, and management is just restricted to the reduction of the predisposing factors. Okay. This is also known as median candidiasis of the tongue, paramedial rhomboid glossitis, central papillary atrophy, posterior lingual papillary atrophy, and posterior midline atrophic candidiasis. But the most accepted and the recent name is this one: posterior midline atrophic candidiasis. Remember, median rhomboid glossitis, which was thought to be of a developmental origin, now it is considered to be of a you can say infectious origin. Okay, here you can see kissing lesion. The lesion that is there on the tongue will get transferred on the palate. Okay. Then there are secondary oral candidiasis, where our body is such condition that it is you can say predisposed to any kind of infection taking place. If the candidal infection is taking place, we'll have secondary oral candidiasis, not just oral cavity, even of the other parts of the body, such as our nail also. Okay. Then comes hairy leukoplakia. Oral hairy leukoplakia is corrugated white lesion which occurs on the lateral or ventral surfaces of the tongue in patient with severe immunodeficiency. It is second most common HIV associated lesion. The marker of disease activity associated with low CD4 lymphocyte count, that is seen in HIV. It is not pathognomic of the HIV because even patient is having other immunodeficiencies such as immunosuppressive agents. If you are giving to them, they will have the hairy leukoplakia. It was first reported by Greenspan, and that's why it is also known as Greenspan lesion. Okay, that is now there is another thing called from the name of Greenspan, a Greenspan syndrome. What is Greenspan syndrome? Can anyone tell me? Anyone? What is Greenspan syndrome? What does it consist of?
Hypertension, Lichen planus, and
Yes, very good. And
Diabetes.
Diabetes.
hypertension, lichen planus, and diabetes. When it is Greenspan lesion, it is hairy leukoplakia. Greenspan syndrome, on other hand, is hypertension, diabetes, and lichen planus. You can remember like this: HTDML. Okay. Now, this hairy leukoplakia I told you is by our. It is seen in HIV infection. There was another condition, Kaposi sarcoma, that was also there in HIV patients. So HIV patients, they have hairy leukoplakia, they have Kaposi sarcoma. Kaposi sarcoma is caused by which virus? Which virus was causing Kaposi sarcoma as we discussed?
HHV8.
Yes, it was HHV8. And hairy leukoplakia is caused by which virus?
HIV.
It is Epstein-Barr virus. Okay, remember this thing. Although hairy leukoplakia and Kaposi sarcoma, both of them are features of HIV, but they are not themselves caused by HIV. Kaposi sarcoma causative agent is HHV8, human herpes virus 8, and hairy leukoplakia is a feature or a condition seen in HIV, but also other immunosuppressive conditions that is caused by Epstein-Barr virus. So this can be asked in an exam that hairy leukoplakia, the causative agent for hairy leukoplakia is, and you'll be in hurry writing the exam. You will be having this time constraint. You want to finish the paper quickly. You will see hairy leukoplakia where it is seen. Okay, it is seen in AIDS. Let me click on HIV now. Hairy leukoplakia is caused by EBV. Kaposi sarcoma is caused by HHV8. Is it clear to everyone?
Yes, sir.
Yes, sir.
Okay. Hairy leukoplakia, EBV, Kaposi sarcoma, HHV8. Kissing lesion. It is in from the tongue to palate. Kissing disease is infectious mononucleosis.
Mononucleosis.
Greenspan lesion is
Hairy leukoplakia.
hairy leukoplakia, and Greenspan syndrome is hypertension, diabetes, and lichen planus. Is this clear to everyone? Now, this certain things you need to remember, which can be asked you in exam. If you know this concept, these concepts are clear to you. No? Whichever way they ask to you in exam, you will be able to answer. Okay, shall we move on? Okay, so we were discussing about hairy leukoplakia. So it is associated with the Epstein-Barr virus, and it also has correlation between smoking with the hairy leukoplakia. So what you will see this leukoplakia, a white lesion on the lateral surface of the tongue where you will see kind of, white patch with hair-like growth coming out of it. Okay, this was the infectious origin that we are discussing. Next is premalignant lesions. Now, premalignant lesions can be classified into leukoplakia, erythroplakia, and OSM. For as far as the red and white lesions are concerned. So, oral leukoplakia, as you were telling, is a keratotic plaque which is in our mucous membrane. For definition purpose, it's a white patch of plaque which cannot be characterized clinically or pathologically, and it cannot be scraped off. Etiological factors will include tobacco product, ethanol, hot, cold, or spicy foods, alcoholic mouth rinses, occlusal trauma, sharp edges which constantly keeps on irritating. All of them will lead to, or all this condition will continuously irritate the epithelium. Now, when you continuously irritate the epithelium, two things can take place. One is either the epithelium, epithelium will react in two ways. Either it will show atrophy or it will show hypertrophy. Whenever it shows hypertrophy, we'll see leukoplakia, and whenever it will show, kind of atrophy, you will see thinning of the epithelium, reddish patch you will see, right? That we are going to discuss next. So clinically, it is asymptomatic. Patient will not even have any symptoms. It can be seen in lip, vermilion bottle, buccal mucosa, any place of the oral cavity you can find leukoplakia. The borders are distinct or indistinct, smoothly contoured or ragged. Usually, the borders are distinct. They can be easily differentiated. Like we can easily tell where the leukoplakia has ended and where the normal skin has started. They can be solitary or they can be multiple areas scattered throughout the mouth. Usually, the floor of the mouth and the lateral wall of the tongue, if they are involved with this leukoplakia, there are more chances that this leukoplakia may get converted into a malignancy. So this can also be asked to an exam, that the site of this, what you can say, leukoplakia, which is most commonly or more associated with transformation into malignancy, it will be floor of mouth. The second one is lateral border of the mouth. Now, this leukoplakia can be classified further. Either it can be homogeneous, that is continuously white, well demarcated, and the pattern you can say crack mud appearance here. Okay, this is homogeneous leukoplakia. Then you can have speckled leukoplakia, which has white part as well as red part throughout the area. That is speckled leukoplakia. This speckled leukoplakia also has higher chances of malignant transformation. Then you have erythroleukoplakia. Here there is combination of red patch and white patch with segregation of red and white components within them. You have erythroleukoplakia, you have leukoerythroplakia. When you have more red part, it is erythroleukoplakia. When you have more white part, you call it as leukoerythroplakia. Okay. And then there is verrucous leukoplakia. When there is large white verrucous areas to small nodular structures. Okay. Verrucous means a kind of growth, proliferative growth that you see from the skin. Here you can see this growth is there. Now this growth, as you are seeing, these are the verrucous growth. This is proliferative verrucous leukoplakia. This also has higher chances of malignant transformation. Right? That was reddish pre-malignant lesion. Whitish. The reddish pre-malignant lesion, we have erythroplakia, which is a pre-malignant condition. Very high chances of malignant transformation within this condition we see. The provisional diagnosis is made when lesion cannot be diagnosed as any other condition, and for definite diagnosis, we have to do the biopsy. With we have to find out the susceptible, so you can say suspected etiological factors. We have to find whether the patient smokes, whether the patient is having tobacco habits or not, and then we have to do histopathological examination. So what happens? Most of the cases are associated with the smoking. They exhibit pre-malignant, malignant changes within them, and erythroplakia is most often regarded as earliest sign of asymptomatic oral cancer. Okay, so whenever you see erythroplakia, there are high chances that it may get converted to oral cancer later on. You can see in the image the red patch on the lateral border of the tongue and on the buccal mucosa, as we can see in this case. Okay, so this can be homogeneous form, red in appearance, patchy of erythro and leukoplakia, or speckled erythroplakia or granular erythroplakia, we can see. So highest aggressiveness is in the homogeneous erythroplakia, then the leukoplakia or speckled erythroplakia. Floor of mouth, if it is there involved, is the most common site in the men for involvement. When it is involved in female or the women, the mandibular gingival alveolar mucosa is the most common site for the erythema. The retromolar region is the second most common site in the both the genders. In the male, the most common site is floor of mouth. In the female, most common site is mandibular gingival alveolar mucosa, and the second most for both of them will be retromolar region. Then this, when you see the erythroplakia, as they told that most of them will have some of the malignant changes or pre-malignant changes. These are known as epithelial dysplasia, where the malignant or kind of malignant changes seen in the epithelium not yet entered the our connective tissue, a kind of carcinoma in situ kind of condition. So this, what all condition you will see, if this is the basement membrane and these are the basal cells, that is the cells just above the basement membrane, what you will see? You will see loss of polarity of the basal cells. Polarity will be lost. There will be presence of more than one layers of the cells having basalate appearance. Usually there is only one layer of, but you will see multiple basalate cells layers. Increased nuclear to cytoplasmic ratio. That is, if usually if this is the cell and this is the nucleus, instead the nucleus size will increase. So nucleus to cytoplasmic ratio will increase. Here the nucleus is small, so ratio is lesser. When you see increase in the size of nucleus, you will see increased nuclear to cytoplasmic ratio. There will be drop-shaped ratty ridges, irregular epithelial stratifications, increased number of mitotic figures, and the mitotic figures in the abnormal form also you will see. So this is the list of the epithelial dysplasia. You can go through the lecture notes after the lecture is over from this. We are not going in much detail into this. Okay. Next is oral submucous fibrosis. That is a normal condition where when the patient is chewing tobacco, most commonly affected or the positive agent is areca nut. Within the areca nut, you have arecoline. This arecoline will go and act on the collagen fibers in our body and lead to their fibrosis, leading to decreased count of oral submucous fibrosis. First, the squads in 1952 gave the name Atrophica idiopathica mucosa. In 1953, Dr. Joshi in Mumbai called this condition or redesignated it as oral submucous fibrosis. What are the etiology? First of all, within the areca nut, we have arecoline, which is the etiological factor. This arecoline will go and affect the collagen fiber metabolism that will lead to decreased degradation. That is, the degradation of the collagen fibers which should be taking place at a regular interval will be stopped. Okay, and more collagen formation will be there. So one that was supposed to get discarded is not getting discarded, and more is continuously getting added and added and added. So that what it is causing? It is causing more deposition of the collagen fiber, leading to fibrosis. Okay, this things we have seen. Now clinically, early cases, what you will see: burning sensation in the mouth, patient not able to tolerate the spicy food, dryness of the mouth, defective gustatory sensation, excessive salivation, small vesicle finding, fatigue, and pain when the bends are formed. These are the early oral submucous fibrosis clinical features. In the advanced cases, what you will see, there will be white marble-like appearance of our oral mucosa with, or when you palpate, you can see fibrous bands throughout the mucosa. You can see erythema oris, that is throughout the mouth opening, there will be a band formation that will reduce the size of mouth, a kind of microscomia condition it will cause. If the tongue base is involved, you will not be able to move the tongue properly. There will be difficulty in the opening of the mouth, eating, patient will not be able to whistle or blow because this area that we are getting in the normal elastic skin, that will be lost. So even the patient tries to blow, it will not be there. Okay, there will be difficulty in swallowing, increased fibrosis which interferes with the speech, and 25% of the patient with oral submucous fibrosis also have leukoplakia in the advanced stages. Okay, you can see glossy skin, blade-like, patient not able to open mouth, not able to rest, protrude the tongue out, and here the fibrous bends formation you can see in oral submucous fibrosis. Diagnosis clinically: palpable bends, this mucosal marble-like texture, blanching of the mucosa, and the histopathological features are seen. There is atrophic epithelium, loss of reticules, and this juxtaepithelial hyalizations. Now there are certain immunopathological conditions which lead to red and white lesion. Now certain conditions like pemphigus, pemphigoid, when they rupture, they appear as red lesion. That I am not going into detail because already we have discussed that. What we are going to discuss here is oral lichen planus, drug-induced lichenoid reactions, and other lichenoid reactions like GVHD and lupus erythematosus. We are going to discuss them in detail next. Lichen planus. So a very common condition you can find in your clinical cases also. It's a chronic inflammatory disease that affects the skin and the mucous membrane, and one of the most common of all the oral diseases. Under the lichenoid reactions, you have lichen planus, contact reaction, drug eruptions, and graft versus host disease. Etiology, obvious etiology is not known, but what we suggest, or what it has been suggested, that the immune system plays a primary role by the subepithelial band formed in the infiltrate dominated T lymphocytes. So what happens in here also, our own cells of the skin of the oral mucosa are marked as antigens by our system's antibody. So autoreactive T lymphocytes will be taken to this area, leading to death of these cells. Here also acantholysis will be there, that will lead to lichen planus. So cutaneous lesion is seen whenever there is oral lichen planus. Even 15% of them will have cutaneous lesion also. The classic appearance of the skin lesion will have pleuritic erythematous to violaceous papules, which are flat top. They have a small angular, only few millimeters in diameter than this. Okay, the large plaques, they are covered by a fine glistening scale. The surface is covered by characteristic very fine grayish white lines. They are known as Wickham striae. Wickham striae, that is radiating lines around the lesion. You will see that is what diagnostic of lichen planus, and it occurs bilateral. Now you know what happens if this is the skin, no, this is skin, and let's say this is the area which is affected by the this inflammatory reaction, as we see in oral lichen. Now oral lichen planus, remember, is an inflammatory condition. Although autoimmune has a part to play here, but it is a, you can call it as a but it is basically an inflammatory condition. Now what happens, the lymphocytes which are going and attacking a particular type of cells, the area which will have maximum lymphocytes affecting the cells, they will be reddish in color. Reddish in color means that area will be atrophic. So as I told you, our body or our skin or epithelium for that purpose will react to this lymphocyte attack in two manners. One is atrophy, other is hypertrophy. So when there is very less amount of irritation caused by this inflammatory cell, what it will cause? It will cause hypertrophy. And when it goes beyond a certain level, the cells will start to die, there will be atrophy. So in the center area of lichen planus, there will be increased activity. So that area will appear reddish in color. So it will be atrophic. But the surrounding area where the inflammatory reaction has not increased that much will show hypertrophy. So this hypertrophic area surrounding the lichen planus, this dot linear strings, that we know as Wickham striae, whereas the center part is atrophic part that we just now discussed. So one diagnostic feature of lichen planus is that it appears bilateral. If you see it on the right side, it will be there on the left side also. Usually it is seen on the flexor surface of the wrist and inner aspect of our knees and thighs, as well as on the trunk. You have to remember 6 P's for the lichen planus. Purple, polygonal, that is different, or you can say not symmetrical in shape. Polygonal will be there. It is planar. It is pleuritic. Itching sensation is there. Papular plaque formation will be there. These are the 6 P's of lichen planus. Remember this thing. Then it also has Koebner phenomenon. Koebner phenomenon means, let's say you have a lichen planus at this place, for example. Now, if you scratch surrounding that area, the area which gets trauma will also have appearance of the lesion there. That is Koebner phenomenon. Okay, the most frequent extraoral mucosal site is genital mucosa, and the classical skin lesions, as I told you, is described in the 6 P's. Oral cavity can have different type of manifestation of this lichen planus. We have different type of forms of oral lichen planus: reticular, papular, plaque, bullous, erythematous, and ulcerative. The reticular part is where you see multiple fine white striae, Wickham striae. That is a reticular form. Reticle means like a thread-like appearance. When you see, that is reticular form. This can be asked you image based also, that which type of lichen. This image shows which type of lichen planus. The answer will be reticular lichen planus. Then there is papular. Instead of the threads, you can see dots as appearance. So when you see dot-like appearance of the oral mucosa or on the oral mucosa, we call them as papular form of oral lichen planus. Then your plaque lichen, as we had seen Candidal leukoplakia or oral leukoplakia, here also you will see homogeneous, well demarcated white plaque surrounded by Wickham's striae. So this striae are what going to help us differentiate them. It is similar to the homogeneous leukoplakia. It is most often encountered in the smokers. Then your bullous form, where there is formation of a bulla. Okay, it resembles erosive lichen planus because the bulla don't stay much and they rupture. This erythematous or atrophic oral lichen. So other things we have seen are the ones which are causing increase in size of the or the thickness of epithelium leading to whitish appearance. Erythematous form, there is so much inflammation that the cells will die, leading to atrophy, characterized by homogeneous red area, and you will see striae at the periphery because those areas are not having that much of inflammation. So it exclusively affects the attached gingiva. When it exclusively affects the attached gingiva only, it will present as these primitive gingivitis. Now, this lichen planus, yeah. So this lichen planus that we are talking about. So this striae on the buccal mucosa, here you can see this center part is red and the surrounding area is whitish striae. Okay. Here you can see gingival involvement. Here you can see atrophic area here in the atrophic lichen planus. Then there is ulcerative tendon. See, atrophic candidiasis is where the epithelium size is reduced. Ulcerative form, whole of the epithelium is basically lost. That is ulcerative form. The definition of the ulcer is when there is breach in the continuity of the epithelium, we call that as ulcer. So in the ulcerative form, that much part of the epithelium is lost. Okay, so it is a disabling form of oral lichen planus. It is fibrin-coated ulcers are surrounded by the erythematous zone, frequently displaying the Wickham's striae. They come and the patient here complains of a smarting sensation or itching sensation. Okay, here you can see this central ulcerative area surrounded by the Wickham's striae here, right? And then there is lichenoid reactions. Now, this lichen planus, I told you, is kind of autoimmune condition. Our body, because of so and so reason that we discussed previously, antibodies will go and affect the cells, leading to cell death through the inflammatory reaction, which is causing this problem. But this drug-induced lichenoid reaction, here what will happen? A drug which has been given to a patient in the form of systemic application or contact with the oral mucosa. For example, let's say you have given a patient a crown, a metal crown. Now, the patient got allergic reaction to this crown leading to the lichenoid reaction. That is also seen, right? So, metal, use of a food flavoring, all of them can lead to lichenoid reaction precipitation. So, drug-induced, usually it is little to distinguish drug-induced lichenoid reaction from the actual lichen planus. Based on history, you can differentiate. Lichenoid lesion include lip. They are symmetric in distribution, also involves the skin, most likely to be drug-related. Histopathologically, this lichenoid eruptions, they show deep as well as superficial perivascular lymphocyte infiltrate rather than classical band infiltrated lichen. Now, a patient comes to you with this features of lichen planus. Now, you want to diagnose whether it is lichen planus or whether it is lichenoid reaction. There is one way with which you can diagnose. That is the histopathology. See, classical histopathological feature of lichen planus is same, only all the features of retipex that you see is same in lichen planus as well as lichenoid reaction. But in the lichen planus, the inflammatory infiltrate that you see in the connective tissue band will be a band-like. And this band-like infiltrate will be towards the top part of the connective tissue or just below the basement membrane. But in the lichenoid reaction, it will be spread to the deeper part of the connective tissue. That is how you can differentiate between the lichen planus and the lichenoid reaction. Okay. The important cause of lichenoid reaction includes cold therapy, oral hypoglycemic agents such as sulfonylurea, antihypertensive, NSAIDs. All of them can cause lichenoid reactions. So drugs basically it is same as kind of erythema multiforme. These drugs and the metabolite that trigger the lichenoid reaction and ultimately leading to T cells or cytotoxic cells going to the site, killing the cells. Clinically, the unilateral ulcerative reaction pattern you will see, they should be considered clinically indistinguishable. When if they are not separable separately, we should consider both of them and then do the treatment accordingly. The lichenoid drug eruption appears similar to lichen rubber planus and may be severely pruritic when there is so much of itching sensation is there. Okay. The diagnosis of the oral lesion comprise of a white reticulum, papule, concurrently with the erythematous and ulcerative lesion. And the correct diagnosis is easier when the patient develops drug-induced lichenoid reaction after starting a new drug. And when you stop the drug, those reactions will disappear. How you can treat that? Same thing, discontinue the drug that is causing the condition and do the symptomatic. Okay. Then there is condition known as lichenoid reaction of graft versus host disease. Now this is important. Two factors are there. First is graft rejection, and the second part is graft versus host disease. Now how both of them are different? Let's consider this thing. This is a patient and this is a donor, right? Now this donor is giving kidney to this patient. This patient donated the kidney to this patient. When this donor donated its kidney to the patient's immune system will find this particular kidney that or the graft he got from the other patient as something foreign, and the patient's immune system will go and attack on this graft. That will lead to failure of the graft. That is, the patient's body rejected the graft that was placed. That is known as graft rejection. And the second thing is graft versus host disease. What is graft versus host disease? Everything is same only. This is patient, and this is donor. Now this donor gave a graft to this patient. Now in this condition, what is happening? The patient is already immunosuppressed, either naturally due to the natural causes or through the immunosuppressive agent that is given to this patient. In this case, what will happen? The donor is immunocompetent. The donor has all the immune system working nicely. So the immune cells present in the graft, when they go out and act on the patient's body, and there they cause these lesions in the patient's body. These lesions are known as graft versus host disease. Whereas in the graft rejection, when the patient's body rejects the graft, that is the graft rejection. Remember this. Okay, is this clear to everyone? Difference between the graft rejection and the graft versus host disease?
Yes, sir.
Other?
Yes, sir.
Yes, sir.
Okay, so this can be asked you in the question form also for your exam. So you should remember this. Let's move on to the next topic. This graft versus host disease, this same thing only that I told you. Clinically, you will see skin lesion with the pruritic maculopapular and multiforme rashes there. Then you will see this violaceous scaly papules and plaques, generalized erythroderma, bulla formation, toxic epidermal necrosis like epidermal discoloration. So these things are basically same as what we discussed previously, and this will not be asked you in the exam also. So just get the concepts clear. Diagnosis: there is presence of systemic GVHD that facilitates diagnosis of oral mucosal changes. So that is a person who recently received the graft and he has this oral lesion, and not just oral lesion, he has same lesion on the skin and other oral part of the body also. That is what we can diagnose this condition as GVHD as compared to oral lichen planus. Differential diagnosis: Candidiasis, easily diagnosable. Toxic reaction to chemotherapeutic drugs, obviously we can based on the findings we can differentiate. Other viral infections, herpes and cytomegalovirus infection, based on certain investigation, and lichenoid drug eruption. All of this based on certain investigation we can differentiate it from the GVHD. And then there are certain toxic reactions. There is reaction to smokeless tobacco and smoker's pipe. Now smokeless tobacco, that is chewing tobacco. When the patient puts in the vestibule, that area will keep on getting irritated. That will lead to this condition known as what do we call this condition as you can see on your skin? Anyone? This is known as tobacco quid lesion. Tobacco-quid lesion is there. Okay. Then there is smoker's palate. In the smoker's palate, that is obviously as the name suggests, you see the lesion on the palate of the patients who are smoking. So what you will see papules with red or dark dot at the center. So what is it? They are basically inflamed minor salivary gland present in the palate with inflammation of the opening of the salivary gland. That is why they are appearing in such appearance. So dark brown pigmentation of the mucosa with the white leather lesion on the palate with the red dot observed, basically showing opening of the accessory salivary glands. They are more prevalent in men and they are common in high consumers of the cigarettes and the reverse smoke. Reverse smoking is seen. Now this is also a question. That's why I'm telling. Reverse smoking means usually when a person smokes, they smoke such that the lighted part of the cigarette stays outside the mouth and from other side they'll inhale the smoke. In the reverse smoking, they put the one that is they have lighted the BD or the cigarette that they have lighted from that side, that they'll put in the oral cavity and then they'll smoke. That is reverse smoking. That is seen in a Andhra Pradesh area and it is known as chutta smoking. CHUTTA, chutta smoking, that is seen in certain parts of the Andhra where this kind of smoking is seen. Now this kind of condition will lead to or increase the chances of malignant transformation. Other red and white lesion, geographic stomatitis. This we are going to discuss when we discuss this disorders of the tongue. So I'm not going into details. Leukoedema. Leukoedema is a kind of condition. It can be associated or cannot be, may or may not be associated with the smoking, where there is white veil-like appearance is seen on the oral mucosa, which is a normal apparent. And when you stretch the mucosa, it will disappear on stretching. That is the diagnostic feature of the leukoedema. White spongy nevus is an autosomal dominant disorder which you see at birth or as the childhood or young adult life. You will see presence of this white spongy nevus on the buccal mucosa or tongue. Okay, this is also white appearance of the oral cavity. Hairy tongue. This we are going to discuss when we discuss the disorders of tongue. Not going into much detail. Basically, here there is increase in the length of our filiform papillae, which becomes pigmented due to the food pigments that lead to blackish discoloration of elongated filiform papilla, leading to black hairy tongue. Clinically, what you will see impaired discrimination, elongated papillae. The length can be as high as 15 mm. Okay, so this were the red and white lesions of the oral cavity. And the last part that we are going to discuss, we have discussed skin and vesiculobullous lesion, we have discussed red and white lesion, but within them we have discussed infections also. In the skin and vesiculobullous lesion, we have discussed the viral infection. In red and white lesion, we have discussed this fungal infection. Right now, we are going to discuss tongue disorders and pigmentation. This is going to be our last topic for the day. After this, you can have your lunch break and you can start preparing for the application for the next week also. One topic of oral metabolic disorders or the oral manifestation of the metabolic disorder we are going to cover in the next session along with them. Okay, so bear with me. I know you must be hungry, but we'll finish this session mostly in half an hour and then you'll be able to have your lunch also. We are not having lunch break before this session. Is it fine with everyone? Shall we continue?
Yes, sir.
Okay. So first is developmental disturbances of the tongue or the tongue disorders that we are going to discuss. So first thing is, first developmental disorder of the tongue that we are going to discuss is aglossia or microglossia. As the name suggests, aglossia means when the tongue is absent. Microglossia is when the size of the tongue is small. Aglossia or microglossia are kind of rare conditions. And they are also associated with the other anomalies of the hand and feet, or cleft palate or dental age muscles. Microglossia, there is also lack of muscle stimulus, and because you see our muscle, our all the bones as such, they grows along with the soft tissue around it. There is a soft tissue matrix surrounding the bone which helps in its growth. This thing in detail we'll discuss during the orthodontics classes. But still, the tongue as it goes, it pushes the mandible of a child, and along with that the mandible also. But when there is aglossia or microglossia, when the muscles are not giving enough of the push, even the mandible will fail to do. So there will be micrognathasia also. That is decrease the size of the mandible. Right? Then there is macroglossia. Macroglossia is reverse of microglossia. That means increase in the size of the tongue. Now the increase in the size of tongue can be true or pseudo. Now how it is true and pseudo? True means actually the size of the tongue has increased, congenital or acquired. But pseudo macroglossia means the tongue's size is same only, but because it is in such a condition that it will appear big. That is, let's say the patient's jaw is small. If the jaw is small and the tongue is at normal size, still it will appear that the size of the tongue is more. Second is atonia. When the tone of the tongue is lost, it will be spread out. Although it is of same size, but because it will spread out, it will appear it is increased in size. Certain vitamin deficiencies or certain neoplasm which displace the tongue. Let's say neoplasm of the floor or the base of the oral cavity that will displace the tongue, making it a bit of larger in size. Okay, a true macroglossia can be congenital, that is from the birth, or acquired, that is after the birth certain disease condition took place that led to increase in the size of the tongue. Congenital macroglossia. Now this congenital macroglossia can be due to, one is muscle hypertrophy. The muscles within the tongue, when there is increase in the size of these muscles, it will lead to increase in the size of tongue. The glands within the tongue, when there is hyperplasia of the glands, it will lead to increase in the size. Certain syndromes like Down syndrome and Beckman-Witt syndrome, Beckman-Witt syndrome will lead to increase in the size of the tongue. And whenever there is lymphangioma or gargoylism, all of them will lead to increase in the size of the tongue. That is congenital from birth. But in other cases, hypothyroid, syphilis, candidiasis, amyloidosis, acromegaly, sarcoidosis, all of these conditions are acquired. So at birth, the size of the tongue was normal only, but as the disease took place, it led to increase in the size of the tongue. Next condition affecting tongue is ankyloglossia. Ankyloglossia means tongue tag, other names. That is, our lingual freedom is attached so high to the tongue or as much as to the tongue tip, there is decrease in the movement of the tongue, and it can also lead to the speech problems. Next is cleft tongue. Cleft tongue, that means deep moving in the midline of the tongue, which is associated along with the tongue, this cleft associated with the orofacial digital syndromes as well. Then there is fissured tongue, also known as scrotal tongue. There is so many fissures throughout the tongue, it appears as if it's a scrotum, right? Now this condition is associated with the syndrome known as Mackerson-Rosenthal syndrome, where along with the scrotum tongue, you have the colitis dendromatosa as well as the facial palsy. Now also seen in Down syndrome. Now this fissured tongue as such itself is not a problem, but because there are so many fissures on it, when the patient is doing regular tongue cleaning hygiene practices like tongue scrubbing, in that cases patient will not be able to clean it properly from the fissure area. So there are chances of food lodgement or the particles lodgement, bacterial growth, ultimately leading to burning sensation to the patient. So the fissured tongue patient, if comes to you with the complaint of burning sensation, although you may not be able to see visible fungal growth, but still chances of candidal infection is there. And in those cases, you have to treat these conditions with the topical antifungal that will prevent the further growth as well as treat the existing infection. Also, you can give topical, this anti-analgesics for treatment of the burn. Next is median glomerulocytis, as we already discussed when we were discussing the fungal infection. Now, this condition is basically known as posterior midline candidal infection, atrophic candidiasis, right? Previously, it was thought to be a developmental origin where it is seen on the dorsal surface of the tongue along the midline anterior to the foramen cecum. The usual size of this condition is rhomboid or oval with well demarcated shape. It is red, flat or slightly multilobulated and smooth. When you touch it, the area is depapillated. The size usually can be 1 to 3 centimeter, and it can cause the kissing lesion as well. Now it is called as posterior midline atrophic candidiasis, already discussed about. Benign migratory glossitis, also known as wandering rash of tongue. Now this is also a kind of developmental condition where you will see an area of depapillation on the tongue. But the thing is, the area of depapillation will not stay at the same size. If you see the patient today, you will see area of demarcation or depopulation at this area. Then after some time, when you check the patient, that area will be over this place and over this place. That's why it is called as wandering rash. The rash keeps on changing the place. Also known as geographic tongue. Geographic as in it will look as if there is a map of world that you are seeing. Certain areas of depopulation, certain areas of population, again depopulation. That is depopulation. This is also known as psoriasis or mucositis. Now remember one thing. Two things are there. First is the patients with psoriasis also have presence of benign migratory glossitis. Get it? The patients who have psoriasis, they may or may not have benign migratory glossitis. But benign migratory glossitis is not associated with psoriasis in any way. So you can be asked in exam that which of the following conditions is associated with benign migratory glossitis. They'll give you three options, one of them being psoriasis, last will be none of them. The answer will be none of them. That psoriasis is, the benign migratory glossitis is not associated with psoriasis or any other condition. Okay, that is benign migratory glossitis. It is associated with the human leukocyte antigen, that is HLA-DR5. And histopathologically, what you will see? You will see neutrophilic exocytosis. Within the epithelium, you will see abscess formation, that is known as Monroe's abscess. Thin, long red ridges and small epithelium over papilla. Now remember, this can be asked in exam. Monroe's abscess are associated with, out of the four options, the answer will be this benign migratory glossitis. Then there is hairy tongue, whereas there is defective desquamation of the filium. Remember, all our skin on our oral mucosa, there is desquamation process going on, the cell turnover going on throughout the day. The cells, as they age, they will be discarded by our body and new cells will come in there. But what happens in this condition is the filium papilla, the cells which are supposed to get discarded remains there and new cells keep on coming. So the filium papilla, which was of this size, it will keep on growing more. So size of filium papilla will increase. It can go as much as 1.5 centimeter, is 10 to 15 millimeter increase in size can be. So it will appear as if the hair is there on the tongue. And because we eat certain things, it is going to cause pigmentation of this filium papilla. That's why it appears as blackish hair on the tongue. And that's why we call it as hairy tongue. It is usually asymptomatic, but because it is hairy, again, same as the fissured tongue that I told you, it can lead to secondary fungal infection that can lead to this burning sensation or other problems. So it can lead to glossopyrosis. What is glossopyrosis? Anyone? You have to find this out. Glossopyrosis, glossodynia. Let me know on the group once you have found the answer. We'll discuss it. Okay. Next is halitosis. Because there's so much of food and all the bacteria and all the fungus are there in the tongue, it will lead to bad smell. That is known as halitosis. Okay. Histologically, what we will see? We will see increase in the length of the filium papilla. There will be mild hyperkeratosis. There will be inflammatory cells present as well as the debris which will be accumulated. Okay. Then another developmental thing you will see on the tongue is lingual varices. Varix means dilated tortuous vein. This kind of the vein you see on the legs also. Okay, varicose vein kind of things. So this is on the tongue, varicose vein on the tongue, that is lingual varices. This is a dilated tortuous vein that is due to increased hydrostatic pressure and which is poorly supported by the surrounding tissue, that is known as lingual varices. We can have lingual Rennie veins also, which is red to purple short-like clusters of the vessels, which are seen on the ventral and the lateral surfaces of the tongue. Okay, so there is no direct association between the variosities and the any other organic disease. That is our varicose veins. It is usually suggested to be due to our aging process, and it is usually seen less than, if it is present less than 50 years of age, it is suggestive of premature aging. Ultimately, it is due to aging. Okay. Now, this was about the tongue disorders. Certain other tongue disorders are there, like you can say hypoglossal nerve palsy or loss of taste sense. So that those things we are going to discuss when we are discussing oral surgery trauma. Okay. So this is oral pigmentation, which we are going to start. Pigment means any color or coloring agent, right? That is causing this discoloration of our skin or mucosa. Now, normal mucosa Our normal mucosa we know is a pale pink color. It can be deep bluish to purple or even blackish depending on the pigment or depending on this our blood supply. If vein supply is full, vein are there, it will appear as purplish in color. And if it is having blood or you can say arterial supply, it will appear as if it is reddish in color. Okay. The normal range depends on melanogenesis, how much melanin is there, how much keratin is there, what is the depth of epithelialization, vascularity, all these things we have discussed in red and white lesions, so I am not going into much detail. Now, basically, a pigmentation, a blackish pigmentation is caused by melanin. That we all know melanin pigmentation is there. Now, melanin pigmentation is caused by melanocytes. Melanocytes generates melanin. This melanin discolors the cells. This thing we know, right? Now, the nucleus of this melanin cells, they generate this the melanocytes that are there. These melanocytes, when they are activated by the ultraviolet light, when melanocyte in our body within the epithelium, when the ultraviolet light is exposed on them, they'll produce melanin around the nucleus, and this melanin which is produced will be packed in the pouches. These pouches are known as melanosomes. So once enough of the melanin is stored in this melanosomes, they mature, and this matured melanosome are sent to the dendrites of the melanin to the keratinocytes. Keratinocytes are the cell presence in the epithelium. So this melanocyte will send melanin from itself to the normal cells, and one melanocyte can contact as much as 40 different keratinocytes. Now, because it is contacting as much as 40 different keratinocytes, it will cause pigmentation of so many cells. Just one melanocyte can cause pigmentation of multiple epithelial cells, right? This can be asked in an exam, that one melanocyte can contact how many keratinocytes. How many it will be? Hello? How many keratinocytes can a melanocyte contact? Anyone? Just now I told you. Multiple, but how many? As many as how much?
40.
Yes, as many as 40 keratinocytes can be pigmented by one melanocyte. Okay, so that is the mechanism how the pigmentation is taking place. Now, factors which affect the melanogenesis is how much sun is exposed, drug exposure, hormones, genetic constitution, all of them will cause. So melanocytes, they'll produce tyrosine, which will be converted to melanin, which will be transferred to the adjacent cells, leading to the melanus or the melanin pigmentation. Now, this melanin, these two things are there. Remember, melanocytes, if melanocytes produce increased amount of melanin in the particular area, that thing we will call it as macule, right? Or the area being pigmented without any other changes. But whenever there is increase in the population of the melanocytes, when the cells of the melanin increase, this condition will be benign navy or malignant melanoma, depending on the benign or malignant. So increase in the production of melanin is a benign condition, that is macule. Increase in the number of melanocytes is either benign or malignant condition, as a benign navy or malignant melanoma. So the classification of the this pigmentation can be endogenous, exogenous, drug-related, associated syndromes, or any miscellaneous condition. So last one in this list, you can see nevi of ota. What is nevi of ota? Nevi of ota is hyperpigmentation occurring around the eyes and sometimes in the eyes also. That is nevi of ota. And then we have nevi of ito. That is pigmentation taking place in the areas of neck, scapula, and back region unilateral. Okay, that is nevi of ito. Now, the endogenous pigmentation can be due to melanin, hemosiderin, hemoglobin, or keratin. Melanin itself will cause blackish, brownish, or grayish pigmentation seen in macular nevus. Hemosiderin from the blood will cause brownish pigmentation seen in ecchymosis, petechiae, varices, and hemochromatosis. Hemoglobin itself will cause red, blue, or purple pigmentation seen in varix, hemangioma, Kaposi sarcoma, and other condition. And keratin, If it is causing pigmentation, it will appear yellowish. That is seen in carotenemia and jaundice. Okay, if there are exogenous pigmentation, the pigmentation coming from outside the body, for example, silver amalgam leading to amalgam tattoo. That is, whenever you're doing amalgam restoration, one amalgam particle might go and get get invaded within the skin tissue or the oral cavity tissue. There it will lead to blackish pigmentation. That is amalgam tattoo. A person or a child, when they are using this, you can say pencil within the oral cavity, it goes and gets embedded within the palate. There it will lead to graphite tattoo due to this trauma. Okay, even lead, bismuth, mercury can, if you ingest them, they lead to pigmentation of our oral cavity. And there can be chromogenic bacteria also. Whenever you see greenish discoloration, it is due to the bacterial, chromatogenic bacterial infection. Certain drugs also cause this pigmentation, like quinine, minocycline, oral contraceptives, syndromes, as you can see here, and miscellaneous lesion like HIV infection, all of them can lead to the pigmentation. Okay. Now these are the classification which you can go through when we are going to lecture notes. I'm not going into much detail. Just remember which one is following under which. We are going to discuss them one by one. The first one is melanotic macule. Melanotic macule is nothing but increase in the production of melanin without increase in the production of melanocyte. That is macule. That thing we have discussed. It's a smaller, less than 2 cm in the diameter and pigmented in the color. Histopathologically, we'll see normal epithelial layer with the basal cell containing numerous melanocyte pigment, not melanocyte, but the melanin pigment increase in them. That is, melanosomes will increase, melanocyte will not increase. That is macule. We can do biopsy to rule out any other condition. Whenever melanin containing dendritic cells are seen to extend high into thickened spinous layer, this melanoacanthoma. Remember, three things are there: macule, melanoacanthoma, and melanoma. Macule is melanocytes are in normal number, only increase in the melanocyte pigment is there. Second is melanoacanthoma. Here also the melanocytes are of normal number, but the dendrites which were touching the keratinocyte, they seem to extend high in the spinous layer. Previously they were in the basal layer only, in the macule. When they go as high as spinous layer, it will become melanoacanthoma. And third thing is, when increase in the number of melanocytes is there. If the melanocytes increase, it is melanoma, either benign nevus or a malignant melanoma condition. So let's see about the nevus, the nevocellular and blue nevus. So unlike aphelis or melanotic macule, nevi are due to benign proliferation of the melanocytes. In the macule, there was only increase in the melanin. So here there are two types: nevocellular or intermucous. Nevocellular means they are junctional nevi. They reside at the junction of epithelium and the basement membrane. This epithelium, this basement membrane. If they are present in both of them, we call them as junctional nevi. Right? They are flat and brownish in the color. And then there is intermucosal nevi. That is melanocyte when they are present deep in the connective tissue. These are the intermucosal nevi. So whenever there is benign proliferation of melanocyte, the nevus cells, they are localized in the, let's say this is epithelium, basement membrane, and this is connective tissue. So now the melanocytes have started proliferating because it is nevi. Nevus or melanoma can have melanocyte increase in number. So when they start increasing in number, whenever they are within the basal layer or at the junction of epithelium and basement membrane, this is with the minimal proliferation, we call them as junctional nevi. Remember this thing. Okay. Then you have intradermal nevi. Intradermal nevi, what they will do? Intradermal nevi will have here intramucosal at this area. This one will go within this junctional epithelium, and the compound will be present in the epithelium as well, that is at the junctional epithelium as well as at the connective tissue. Let's see them one by one. So here it is within the junction of epithelium and connective tissue. Then in case of intradermal or intramucosal nevi, what will happen? There will be proliferation down to connective tissue. It will proliferate, it will go in the connective tissue also. That is intradermal or intramucosal. That is compound nevi, seen in both of them. They lose their continuity with the surface epithelium and cells become localized. Now, once they start growing, it will stop being present in the epithelium and separately they will be present in the connective tissue. Okay, this is intramucosal nevus. The blue nevi is nothing but it is something that is not derived from the basal layer. It is blue in color because the melanocytic cells reside so deep in the connective tissue. The overlight vessels or the veins that are passing through it, because of that, it will appear blue. And it differs from the nevocellular nevi because it is having more spindle in shape and maybe macular or nodular. Both nevocellular nevi and this blue nevi, both of them are 0.5 centimeter in size. Then there is compound nevus, as we discussed already. Okay, that is present in the epithelium as well as in the connective tissue. These are the benign conditions. Now, if this condition becomes malignant, then it is malignant melanoma. What causes it to become malignant? That is predisposing factors like sunlight, degree of natural pigmentation, precancerous lesion. All of them will lead to malignant melanoma. Clinically, it appears as macular or nodular. The coloration varies, ranging from the brown, black to the black, with the zones of depigmentation. Basically, malignant melanoma, as you can see here, this blackish depigmentation is there. There is one mnemonic you can remember for it: A, B, C, D, E. A is, this can be asked you in exam, that A, B, C, D, E for the malignant melanoma. In that, A stands for which of the following. Or you can also ask that which of the following is not a feature of malignant melanoma, and they'll list any 3 of this and 4 anything else. So what are A, B, C, D, E? A is asymmetry. It will not be symmetrical in the shape. Border irregularity, the border will be irregular. It won't be homogeneous. You will see color variation within this lesion. Diameter has to be more than 0.6 centimeter and it should be raised above the epithelium, that is elevation. Okay, here you can see asymmetry is there. If you see like this, between 2 parts there is asymmetry. B is border irregularity. C is color variation. Diameter being more than 0.6 centimeter, and E is elevation, that is above the skin level, elevated. So we have seen here different kind of melanomas: superficial spreading melanoma, nodular, lentigo, acral, mucosal, and amelanotic melanoma. These are the types of it. Okay, the lentigo maligna melanoma or Hutchinson's freckle, as it is called. It is on the facial skin lesion, which is atypical melanocytic hyperplasia, or you can say melanoma in situ. It has not yet entered the connective tissue. They spread laterally and superficially. This is epithelium, this is connective tissue, and at this point it has this spread starting. So it will spread lateral like this, lateral and superficial with rapid growth phases there. Here the prognosis is good because it has not entered the connective tissue. Once it invades the connective tissue, no, it becomes difficult because once it has invaded the connective tissue, it will contact the blood, and from the blood it can spread to other part of the body. Okay, so because it is staying within the epithelium part, it is having good prognosis. This is Hutchinson's freckle or lentigo maligna melanoma. Okay, for any malignant melanoma, the classification or you can say staging is done based on 2 methods: Clark's method and Bullous. Okay, the Clark level is level 1 to 5. Level 1 is in situ, that is this maligno melanoma we talked about within the epithelium only. Level 2 is it is, see, and the epithelium also you can classify like this: epidermis, papillary dermis, reticular dermis, the area between both of them, and the subcutaneous tissue. Okay, epidermis, papillary, joining of papillary and reticular, and then subcutaneous. These are the level. So when it is within the epithelium, it is in situ melanoma, level 1 Clark. Level 2 is into the papillary. Level 3 is through the papillary into the reticular. 4th is to the reticular, and 5th to the subcutaneous tissue. These are the 5 levels of the Clark. And the Breslow method is also depending on the how wide it has, how deep it has penetrated. So it is measured from the granular layer. There is BSGC 4 layer there: basales, spinosum, granulosum, and condyle. So it is measured from the granular layer of the epidermis down to the deepest point at the tumor where it has invaded the tissue. That is also regarded as a good indicator of outcome. It is measured in millimeter. So this question is that Breslow thickness and Clark level are used to classify or used to stage each of the following condition. You can be given options like ameloblastoma, squamous cell carcinoma, malignant melanoma, and multiple myeloma. The answer will be malignant melanoma because that is why it is used for. Okay. Now the staging, the TNM staging is that stage 1 is primary tumor without any kind of nodular or metastatic involvement. Level 1 is in situ without evidence of invasion. Level 2 is invasion up to propria. Level 3 is involvement up to the skeletal tissue or muscles. Then level stage, these are the stage 1, level 1, 2, 3 with TNE, N0, N0. Then stage 2, TNE plus N1 involvement, and stage 3 is whenever there is metastasis. Okay. Treatment, radiotherapy, chemotherapy, immunotherapy, and lastly surgical management is there. Okay. Surgery, you have to first, as much as we are possible, we have to reduce the chances of its growth surgically, and then we have to decide whether the chemotherapy, radiotherapy, or immunotherapy is required or not. What agents are used are not important as such for you now, so we are not going into much details. Now, coming to the next pigmentation of the oral cavity or of the face, that is melasma or cholesterol. When a patient is taking oral contraceptive or whenever the patient is pregnant, they are associated with high pigmentation of the facial skin and the periorbital as well as perioral region, that is known as melasma or cholesterol or cloastrol. Okay, so the flat lesions, nail bed, and the skin, all of them are affected in this condition. Then we have endocrinopathic pigmentation that is seen in the Addison's disease or Cushing's syndrome. So what happens in the Addison's disease is, because of course we know that it is involved in the cortex of the adrenal gland. So there is, it leads to the adrenocortical insufficiency. Because adrenocortical insufficiency is there, the steroid hormone decreases. Whenever there is decrease in the steroid hormone, our body will produce ACTH, there is adrenocorticotropic hormone, so that our body can produce more steroid hormone. But remember, the ACTH does not only affect the adrenal gland, it will also affect the MSH. MSH are melanocyte stimulating hormone. And whenever the melanocyte stimulating hormone is activated, it will go and activate the melanocytes, lead to more pigmentation. Okay, that's why more pigmentation is there. Now, this thing, in addition to this ACTH, this same mechanism also acts in the Peutz-Jeghers syndrome. Sorry, in the fibrous dysplasia. In this McCune-Albright syndrome, also same mechanism acts. Because in fibrous dysplasia, more MSH are activated through ACTH, leading to this pigmentation. Peutz-Jeghers syndrome also has this lip platypma in an adolescence with the Peutz-Jeghers syndrome. Here you can see in this image. It's an autosomal dominant condition with oral pigmentation with intestinal polyposis. So here the pigmentation is distinctive with lesion on the anterior part of the tongue and buccal mucosa, and they are focal, melanotic brown macule less than 0.5 cm in the diameter. Then neurofibromatosis 1 and neurofibromatosis 2, both of them can have pigmentations. Axillary freckling, that is freckling in the axillary region, that is also known as the Crow's sign, which is accompanied by 6 or more macules, that is pathognomic of neurofibromatosis 1. Okay, neuroectodermal tumor of infancy, that is one name you should remember for your exam point of view. That this condition is most commonly, where does this condition affect? The condition exclusively affected by the neuroectodermal tumor of infancy is maxilla. Maxilla is most commonly associated or affected by the neuroectodermal tumor. Okay, then coming to the hemoglobin pigmentation. First is hemangioma. So whenever there is raised, nodular, and flat macular lesion, which you can see, that is sometimes you see from the birth, that is hemangioma, which you can call as port wine stain. So it is most commonly seen on the tongue and the lip mucosa. On the tongue, they are multinodular and bluish. It occurs in the childhood, adult, or adult person, anyone. But when it is occurring in the childhood, it can involve you, it can disappear on its own. Okay, if it is close to epithelium, it will appear red. If it is deep in the body, it will appear bluish in this condition. It involves the facial skin. The skin will appear flat and magenta. Okay, now it will also, these vessels that are there, no, in the hemangioma, they'll show calcification. And now, because if this is the vessel, and if the vessels is calcified on the borders, on the radiograph, if the vessel is not calcified, it will not be up there. But if this vessel is calcified, when you take the radiograph, this lining will appear as radio-opaque lines within the X-ray. So these radio-opaque lines are known as trem-line calcification. Okay, and our bone will appear bubbly or honeycomb trabeculate appearance. This we'll discuss when we are discussing bone radiology. Okay, and it will show diascopy positive. Diascopy means, let's say this is the lesion over the tongue. Now, if you press it with a cover slide or the slide with which we are using in microscopy, if you press it, you will be able to see paling or that area being pale, right, when you press it. So that is known as diascopy test, with help of which we can diagnose this hemangioma. Radiographically, you can see sunburst appearance over here, hair on the appearance, kind of, you can see. Okay. Then another condition with pigmentation is Sturge-Weber syndrome, which has encephalotrigeminal angiomatosis, along with that nevus flammeosis, that is port wine stain of the leptomeninges of the cerebral cortex. What is leptomeninges? Can anyone tell me? Can anyone tell me the 3 layers of meninges? Which are the 3 layers from outside to inside? No one?
Arachnoid, subarachnoid, pia mater.
Dura matter. Then we have, which matter is there?
Pia mater. Arachnoid.
Dura matter, arachnoid matter, and pia matter. These are the 3 layers we are having. Okay. So this, the 2 that are inner ones, arachnoid and pia maters, these are known as leptomeninges. Okay. So in this Sturge-Weber syndrome, there is involvement of the leptomeninges of the brain. These patients will have mental retardation, hemiparesis, and seizures. There will be occlusal lesions, and calcification can be seen. Okay, you can see this nervous phlemesis, unilateral involvement, as well as trem-line appearance of the blood vessels here also. Okay. Now there is another condition known as vascular malformation, AV malformation. This may appear same as the hemangioma, but both of them are different. Hemangioma is due to abnormal proliferation of the endothelium of the capillaries, whereas vascular from the normal blood vessel. Okay, whereas vascular malformation is abnormal formation of a whole new blood vessel itself. Right? What are the elements? In the hemangioma, there is increase in number of capillaries. In the vascular malformation, on the other end, there is mix of increase in the number of artery, vein, as well as shunt between A and B. The growth of hemangioma is rapid in the congenital part, and it ceases as it reaches the puberty, and it can sometimes, involve itself spontaneously. But the vascular malformation grows throughout the birth, throughout the life, and it does not involve. Boundaries of hemangioma is circumscribed, and it is easy to treat with surgery, easy to reset. But the vascular malformation, it is very difficult to do the resection. Okay. Then we have Kaposi sarcoma. Kaposi sarcoma, 2 things. It is seen in which patients? Quickly. Kaposi sarcoma is seen in which patients?
HIV patient.
And it is caused by which virus?
Human herpes virus 8.
Yes, it is caused by HHV. So this is a tumor of vascular origin, as we know. It appears bluish or purple because it is present in the deep. And in HIV, seropositive patients, these oral lesions are flat. Red macules of variable size can be seen on the most commonly palatal area. Okay. Then we have the Rendu-Osler-Weber syndrome, where you can see multiple round or oval papules measuring less than 0.5 centimeter. They are genetically transmitted disease, and these purple papules are vermilion mucosa on the lips and tongues and buccal. Hundreds of them you can see. Okay, here you can see treatment is selective embolization and electrocautery for the treatment under local anesthesia. Then whenever there is deposition of the hemosiderin, brownish heme associated with this kind of lesion, ecchymosis, then we have petechiae and the hemochromatosis. Okay, Ecchymosis is where pinpoint multiple areas you can see of blood accumulated in that area, that is ecchymosis. When they are increased in size, we'll call them as petechiae. Their capillary hemorrhage will appear red initially, turning brown, and in few days they are exacerbated red cells. They have lysed and they degrade outside the hemocyte. And then whenever there is deposition of the iron, the excess iron that is there within our body, when it is deposited in a certain area of the part of the body, is known as hemochromatosis. So iron is stored as hemosiderin, and this hemosiderin is deposited somewhere. We call it as hemochromatosis. It is due to increase in ECTH, and oral lesion will appear brown or grayish in color. Lipofuscin, also known as wear and tear pigment of our body, but it is not usually seen in the oral cavity. Exogenous pigmentation we can have due to amalgam tattoo, as we have discussed, graphite tattoo due to the pencil injury. Increased exogenous poisoning such as arsenic, bismuth, or lead mercury, all of them can lead to linear pigmentation of the gingiva. This pink disease or swift disease or ectoderma, that is mercury poisoning, will lead to pigmentation of the skin as well as the oral manifestation, which will lead to ropey, viscid saliva, hot mouth, that is burning sensation being there, and there will be diffuse grayish pigmentation of the alveolar mucosa as well as gums. Lead poisoning, also known as this plumbism, where you will see metallic test in the patient, and there will be irrespective of the absorption of the pathway, the lead is taken up by the erythrocyte, and then they go to the area which has more inflammation. So areas of more inflammation will have more blood supply, and they'll show more pigmentation as compared to the area with the lesser pigmentation. So the person who have lead poisoning will see this dark pigmentation in the gingival, marginal-gingival area. Same way, bismuth also will see blue to black line along the gingival margin. Arsenic poisoning also you will see oral lesions, that is ulcerative lesions you will see along with the pigmentation. Whenever there is silver poisoning, the industrial exposure, it will lead to silver pigmentation of the skin as well as oral cavity, or the patient might appear cyanotic, that is cyanosis can be seen. There is another condition known as Candidiasis, that is due to cold pigmentation. When you are doing cold therapy on a patient, previously it was done cold therapy. So in that case, the cold pigmentation can take place. That is known as Candidiasis. Okay, so this is the argyria, and Candidiasis also appears kind of bluish in the color. So that's all from our today's session. This was our first session of oral medicine. Remember, the next session is going to be the next. So now that you have attended the live class of oral medicine part 1, what we are going to do, you have got topic wise videos for each of this topic that we have covered in your account application. There you can watch those videos. You have a question bank for each of this topic. More than 100 questions on an average will be there. From there you can read these MCQs, and you have got hard copy notes couriered to your place. If you have not got it, you will get it soon. And you have got the online notes also, from which you can read these topics. Even this lecture notes will be available for you for reference. Then once you are done with all this thing reading, you can read from the MCQ books that has been given informed to you, or even if you're not reading MCQ books now, as long as you're using Aspire MDS app, even only using the question bank that has been given to you in the application will be enough, even if you don't want to carry the MCQ books with you. Once you're done with all this preparation, you can go to the topic wise test, take the topic wise test of all these topics, and at the end take the subject wise test for all these 5 topics that you are done on the Saturday. Okay, and next Sunday we'll be having the second half of oral medicine preparation. So those who are willing to join for this course, there are 2 courses going on. First will be for this year NEET MDS exam, that is 1 year duration, NEET MDS 23 online course, and a foundation batch for the final year or maybe third year students who want to start preparing now. It will be a 2.5 years course that will go until December 24. Okay, till then it will be there. We'll be able to prepare for the exam. So that's all for our today's session. Anyone, if you are having any doubts, you can ask me now. Anyone? No doubts? Himanshi, Diya, Jay, Komal, Nidhi, Raveria, Rivya, Shubham. No one is having any
No,
doubts,
sir.
right?
No, sir.
Okay. So, so I guess you all must have got the topics nicely that we have discussed today. Anyways, if you have any doubt,
Hello.
yes,
Sir, I'm Shubham, sir. I had a doubt.
yes,
Sir, in human herpes virus classification, like I am referring to Burkitt, cytomegalovirus is given as HHV4.
yes.
Yes.
So that table that is given in Burkitt, no, is having error.
Yes, sir.
That table we need to change. Burkitt, that table which is giving classification of human herpes virus infection is having that error. So follow the classification that we have discussed in the class below.
Okay.
Okay. Yeah. Anyone with any other doubts?
So please repeat plasmapheresis.
Sorry.
So plasmapheresis.
Plasmapheresis. So see, what is plasmapheresis basically? Let's say there is a patient who is having an autoimmune condition. We are talking about pemphigus. Okay. Now this patient is having pemphigus because this patient is having antibodies which are against the epithelial cells. Correct? Is it clear?
Yes.
Right? Now these antibodies will not be only in the cells or only in the epithelium. These antibodies will be circulating in our serum or in our blood. So what we do in plasmapheresis is we take out the blood from the person, from the patient, we put it in a filter. Now this filter, what it will do? It will filter the serum of the patient in such a way that all the antibodies will get filtered from there. Along with the antibodies, certain proteins also will get filtered. But the proteins which got filtered, we can add again and give it back to the patient. But the antibodies which were causing the problem, the load of the antibodies can be reduced. That condition or that process is known as plasmapheresis. Get it?
Yes, sir.
Yeah. Any other doubts from what we have discussed today? Okay, so I guess no one is having any doubts, but just a few tips that, for those who are starting the preparation now. See, remember, whether you are preparing for this year exam, for next year exam, for 2 years later, the exam date is almost going to be same in the December for all three of this year, next year, the year after that. So those who are going to appear with you in exam, you and those who are appearing with you, they all of them are at same time. Now, what is going to determine how you are going to perform in this exam is how you are going to use your time. If you have a 12 months of time for your preparation, your competitor also has 12 months. Now, for you to get a good seat, let's say you want to get a good government seat in an All India quota. Let's assume that we want to get a rank in top 100 of All India exam. Now, to get in top 100, we have to compete with the 20,000 who are preparing with us. So we have to do something that those 20,000 are not doing. So first step you have taken, that you have started preparing early. Very good. Because you have started preparing early, you will be ahead of them. But does it guarantee your rank? No. You have to use this time also. Not just the starting early is not enough. You have to keep this up. You have got the momentum now. You have started running, but you have to keep on running. Otherwise, it is going to be like a rabbit and tortoise race. You start running now itself, you get tired, you get asleep. Someone starting later on will also overtake. So good that you have started early, but keep the progress. Okay, there will be some days. See, there will be some days where you will not feel like reading, you will not feel like taking your book or something like that. Even on those days, even if nothing is going in your head, you take the book and sit. Don't break the chain. If you have developed a habit that you are reading for 3 hours, 4 hours, 5 hours per day, and one day you feel like you're not reading, you don't feel like reading, if you stop that chain, no, it will become a continuity of not reading. For 3, 4, 5 days, you would have noticed this during your UG preparations also. That you were reading nicely, and then suddenly one day you took break, and then that break of one day went on for 1 week, 10 days, then you have to focus it again. So even if you don't feel like doing it, keep on reading. There will be some days when you will not feel like reading. One day is like 1 day in 3 or 4 months is okay, where you can take a break, go with your friends or something, and at this stage, not at the later stage. If you are appearing for exam after 3 days, you cannot afford to go for outing. But at this stage, in between, one day is okay. You can take a break. But that too should be a reward for you. You should have decided that, okay, I am going to prepare for, if I am going to prepare this much portion in this duration. If I finish this, I'll take a day break for this particular duration. Okay, everyone. So make sure you're using your time nicely and you're not wasting your time on non-productive things. Entertainment is okay. It should not become your over entertainment. Break is okay, but it should not become leisure of 4, 5, 6 days or a week or a month. Okay, so that's all for today. You start reading these topics from our application now. You will get this lecture recorded on the application available, as well as the recorded videos of particular topics which you can read. Notes, you have got the notes. You get online notes also there. Once you are done with them, go to the question bank, take the topic wise test for one topic, move on to the next topic, repeat the cycle. Once you are done with this 5 topics of this week, take the subject wise test, and next Sunday we are going to have the next live session where we are going to discuss the remaining part of the topics. Okay, everyone. Then that's all for today. Bye. Take care. All the best.